Okay, good morning again. We are now officially starting our event. Let me greet everyone who's in the room, everyone who has joined us online via Zoom, Facebook, YouTube. You are all welcome. Before we start our report, it is important for me to say that here we are having a very small number of people because we are respecting COVID-19 regulations, as we know that we are living in times of COVID, and we have to always make sure that we follow all the regulations so that we keep everyone safe. And we are also having 10 groups in different areas of Mpumalanga, which are very small. Also, they are following COVID-19 regulations who have joined us online. We are waiting for people from the Department of Health. I'm not sure whether others have arrived, but I haven't seen anyone here. Anyway, we know that others are joining us online. We hope that they will be able to assist in responding to the demands or recommendations that we will be putting forward today. Today we are launching a report which we call it Mpumalanga State of Health Report. On this report, we have collected data as Richitse, and the monitoring that we are doing in Mpumalanga, it's done quarterly basis at 43 facilities or clinics, and 21 in Hlanzeni, 18 in Garsebande, and 4 in Kankala. This report that we are launching, it's a very recent report, and the data was collected in April and now in May. So how is this data being collected? It is collected through the observation that we go to the facility and look at the observation of the facility, as well as with interviews of patients, adherent club members, key populations, healthcare providers, facility managers, and adherent club facilitators and pharmacists. All recheated data, collection tools, and all our data are at the dashboard, which is available through our website. Our website is www.richitse.org.za. So anyone can be able to access that information. So our program today, it will be a welcoming and overview of the report, as I've already done. And secondly, we'll be talking about community priorities and testimonies, which will be talking about staffing and waiting times, infrastructure, stock out, ART continuity, tracing and rearranging people living with HIV, index testing, key population, tuberculosis, and accountability. So that is, it will be our second item. And the third item, it will be partner organization inputs. As you know that Richitse is a quorum of 5 organizations, which is Treatment Action Campaign, Sanarela Plus, Positive Action Campaign, a Positive Women's Network, and NAPWA. And after that, we will get reflections from the Provincial Department of Health. And after that, we'll get reflections from the National Department of Health. And the last item, it will be vote of thanks. So without wasting any time, I will give to my colleague Ndivue to give us more information on staffing and waiting times.
Thank you, Chair. My name is Ndivue Rambau. I'm a project officer with the Richitse project, and I'll be taking us through the first group of issues on staffing and waiting times. So our Richitse data is finding that both patients and facility managers agree that there are staff shortages at the clinics. According to 800 patients, only 29% of patients said there was always enough staff to meet patients' needs. Managers at 42 facilities agreed that there are not enough clinical or non-clinical staff at the facility, and this comes at 92.7%. So when it comes to which cadres are mostly understaffed, we are finding that in the Mpumalanga State of Report, there's a shortage of professional nurses, enrolled nurses, data capturers, and cleaners. However, that's not just those who are short. There are those that are other staff that are short that are seen in the graph on the presentation. So we have long waiting times that are reported by patients. Patients at about 20 clinics reported average waiting times of 5 or more hours. Patients at 4 clinics reported waiting times of 6 or more hours, and patients at 2 clinics reported average waiting times of 7 hours and more. So essentially, the department and the DSPs should go and focus on the 20 sites with waiting times of over 6 hours to try and fix and find out what the problem is there. We have the clinic names on the dashboard, and we can provide all of the information. We have also found examples of clinics where waiting times are very short, under 2 or 3 hours. It's important to understand what are these clinics doing right. Go to them and learn from them. Take the lessons back to the clinics with long waiting times. What are they doing right that can be replicated? That is a key lesson that can be learned. It is possible to improve waiting times. It is within our reach, and it's something that we can do about it. And that is visible through the clinics that are having the shorter waiting times. The majority of patients thought waiting times were long, but this does vary across districts. So for example, in Nhlanzeni and Gert-Sibande, only 2/3 of patients think waiting times are long. But there are a very high percentage of patients reported long waiting times in Kangala, although we note that we monitor far fewer facilities within this district. So if we look at our data, we find that 52% indicate that there's the long queues, and other reasons given for those long queues amongst the 52% of people is that there is not enough staff. So back in May 2019, we were very happy about the new National Department of Health Circular, which indicated that we should be seeing extended opening times in our facilities. However, 2 years later, we are not seeing that there's much of a change through our monitoring. The most common reason given for facilities being unable to extend opening hours is shortages of staff, as well as lack of resources being thrown into the circular so that it can basically work. We are also finding that filing systems are in a bad condition in some of our clinics that we are monitoring. We have found disorganized, messy filing systems at 10 sites. Disorganized filing systems only add to waiting times as staff are delayed in finding files or lose files altogether. Some patients report having to open new files with all of their patient history lost. But we know that at 32 sites, filing systems were reported as in good condition. Again, what lessons can we learn from them? The department and the DSPs should work together to maintain functional filing systems to improve overall patient experience. The most common complaint is that the space where the files are stored is often too small. There needs to be a plan to address the infrastructural challenges in filing systems in our facilities. So now we're just going to move on to our recorded community stories, which were recorded within communities of Mpumalanga.
Emthonjeni. Solo nje vele ngayicala akukho right lapho because awuye ekuseni around 5 uyofola iline ukuze ukuthi uzokhona ukusheshe ucede yabo. So uzotholakala ukuthi uzofika lapha ngo-5 uyafola uzokuma lapha na ungene eklinikhi naseningenile eklinikhi nakhona nisazolinga iklinikhi iyavalwa ngo-4 kwesinye isikhathi ungalithola usizo nango-3:30 uyayibona ufike ngalo-5 ekuseni iklinikhi nayivula wenzela ukuthi nawe ube sowulapha ngaphandle ufolile line noma kungagcwalanga angeke ngize ngichaze ukuthi bangwa yini because noma kungagcwalanga nje kwesinye isikhathi amafayila ayadileya ufike ungalitholi ifayili isikhathi bakutshela ukuthi ifayili lakho selilahlekile ya bake bangitshela ukuthi ifayili lami abalitholi bamele ukuthi bangenzele ifayili elisha yiko bese kwesinye isikhathi-ke sesiyenhlutha nama-dates ukuthi yo kumele ngeklinikhi uphathwa yi-stress abekho friend shem angifuni ukucamba amanga abekho friend nje noma uzoyencisa i-date akakubuzi kahle ukuthi what's the reason yokuthi ungazanga nge-date eso because bekumele mhlawumbe uze ngeyi-13 waye ufika ngeyi-16 uyakushawuta ngathi ngumntwana omncane you-understand angayazi ne-reason ukuthi why bongazanga ngale-14 mhlawumbe nangabe bekumele uze ngeyi-14 kwesinye isikhathi uvele ufike nje eklinikhi ufike ujike nakhona-ke uyayibona uzofika mhlawumbe mina njengami ngiyasebenza ngizocela emsebenzini ukuthi ngizongena late ngifuna uqala eklinikhi ngiyafika eklinikhi ekuseni kushaya abo-3 ngiseklinikhi sengiyajika ngibuye emsebenzini you-understand so sengimele ngenza ilanga ukuthi mhlawumbe nasengi-off because angikwazi ukucela kaningi nasengi-off ukekhani sengiye nakhona nangifika akasabuzi ukuthi why ukuthi ngizomchazela ukuthi ngijike la ngangalitholi usizo kwaze kumele ukuthi kumele ngibuyele emsebenzini uze ube nje nalowo ukuthi yazi kube nje mhlawumbe ayisile treatment vele ngabe ngiyayeka kwale klinikhi yayibo yabo kuzuze ukuthi eyazi kube kungcono kube mhlawumbe ngine-medical aid ngabe amaphilisi ngiwathatha ka-doctor kunalento yaseklinikhi mhlawumbe ngalokhu yiko basitreat-a so cause izinto zamahhala.
I'm a community healthcare worker, but I would like to be anonymous. Emelo, Encindi. Kakhulukazi nje mangabe siyasebenza e-clinic, let's say angithi we have to siyenze i-screening egedini. So akukho safe kakhulu ngoba at times like this week akuna ma-mask, but sigcina thina sisebenzisa awethu. Only to find ukuthi nangabe umphathi wethu lo OTL akekho kuthiwe ngesiwathole and then we ended up silokhu siwawasha lawo and kufuna uma ufike ekhaya vele uyiwashe ekuseni uyigcoke uyiwashe avela isiphathi kahle because ngeke phela ngicabanga khona abanye abangawashi lama-mask end up umuntu awaphinda and mhlawumbe omunye uzowagcoka until afike ekhaya washiye so kungenzeka nale COVID siyayithatha siyimikise emakhaya. Yayibona siyaye sibeke i-families wethu engcupheni.
Ngiyasebenza eklinikhi and enasisebenza eklinikhi siyanethwa asinandawo abasinaki asinayo nendawo yokudlela noma uscreen kosuncenge uhlele ngaphandle lekumphathi sathi sicela sizamele indawo yokuthi sibeke emabheki nokudla nokuthi nasikhona ukuthenga ukudla sikhona ukudla manje asikhoni konke lokho insiza siyitholi kodwa bayafuna ukuthi sikhone sofuna ama-screening kwamanje bakhiphile inamba ukuthi sofuna ama-screening bayakhona ukusinika umsebenzi kodwa ukusinakelela abakhoni and then nasukwenza lokho siyayifuna inamba siyithole basole bayakhipha nje bona kodwa indawo yokuthi sihlale sikhoseleke kulamaviki apheli kulawa nganethwa kayi-3 ngiseklinikhi and nasithi sicela lamanye ama-sister ukuthi sicela ukubeka itafula la celeni sihlale khona basitshela ukuthi sivale indawo ngoba asinandawo and bona bayakhona ukungena emotweni bangene ema-office bots ema-hitters kodwa thina sinethwa ngoba bathi sisebenzele khona sibasize ukuthi screene abantu kodwa insiza asiyitholi ifoni asinazo kwamanje kwanami ngifake esami nje anginasifoni ngibone ukuthi kungcono ngingafaki lesidale ngisiphindaphinde kaningi kusiwasha ngafaka lesami ngasole ngithi hayi ngizasithola asiyitholi.
Have community members who have joined us to share their individual experience as well. They have opted to remain anonymous, so those who are streaming, you will not be able to see their voices. I'll hand over to a few of our community members.
igama lami nguSimangele Nkosi. Ngihamba ekliniki yaseCindi eThusi. Ngivuka ngo-4. Sometimes ngiriske ngempilo yami ngoba ama-taxi awekho ngaleso sikhathi leso ukuze ngikwazi ukuthi ngizokwazi ukuthi ngingene ngaphakathi. Ngithole vele sekunelayini ngoba khona nabahamba ngey'moto. Ume lapha ngaphandle kumakhaza noma imvula ina isinethe awukwazi ukusuka elayinini because ngoba ngeke uzungene phakathi. Ume bafike ngo-7 mabafika ngo-7 yima basibhalisa. Siyima ilayini sazoma futhi sibuyele futhi siyongena phakathi. Mase singenile phakathi basitshela ukuthi basene-meeting. Sesihleli manje thina ey'tulweni silinda ukuthi basikhiphele amafayili. Nalo sikhiphela amafayili une-attitude. Ngelanga ifayili lami ngiyalifuna angilitholi. Hayi ugcine nini kuze ekliniki? Ngoba nayi ilona yami appointment card lami. Athi mangabe awufuni ngikusize iyekela. Ngihlale ngoba ngiyayidinga lempilo yami. Hayi amangalikhipha uyanginika uyompompa ngale. Ma uyompompa kukhona noklinayo. Maruze kuzopompa. Uyampompa babuka i-high blood yakho abanye bakhuluma ngalendlela abafuna ngayo. Kodwa uzompompa ukukhuluma nomuntu ozoklina. Uhleli nalo sister lo okuzokumpompa. Uphuma vele sewuvele nawo ukwatile. Nala ngaphandle usazohlala ubamba ilayini lokuthi uyongena kusister. Ke mina ke ngeke ngahlala 3 months ngingasayithathi treatment yami. Because mangena vele kunalento leyo kangangokuthi nami ngize ngiphakanye lo moya ngoba nami ngingumuntu. Usister angitshela ukuthi ngizokufa. So nami ngamtshela ngathi ukuthi mina mangifa, ukuthi nawe uzokufa ngoba nami angihlalanga ngenkani. Uyangena mawungena uthi uyangena komunye usister akushiye phakathi eroomini. Uyaphuma uyoxoxa indaba ngaphandle. Ubuya nomunye bazoxoxa indaba zabo futhi khona lapha phambi kwakho. Usosaba nokusho ukuthi ngiyini inkinga enginayo. Makabuza ukuthi ngiright vele ngithi ngiright kuko konke. Ngibe ngizwe ukuthi khona la ngine-pain khona. Noma khona nginenkinga mhlawumbe engifuna ukuyishare naye. Angikhona ukuyishare. Bahleli bayi-5 bayi-4. Uyaphuma uyangishiya. Abuye usister azongitshela ukuthi yena umsebenzi azange agocozise i-ID. Akangazi ukuthi mina ngisebenzaphi. Uma azothi kimi yena akagocozanga i-ID. So konke lokho kuyangihlukumeza mina kakhulu ngoba bese ngicabanga nokuchinja ukuthi ngiye kwenye ikliniki. Vele abasiphathi kahle kangangokuthi isho nalo oklinayo ubaba uklina ikliniki akayiklina ikliniki unathi. Uyasitshela ukuthi ninenzolanda laba bengculazi abeme ngapha. Ninelanda emalona enu abaye efastereni niyazazi ngithi nje ukuthi nefastereni. Wena ongazazi ukuthi efastereni kanti uzokwenzani? Anihlaleni kahle nina bomama kusho ubaba oklinayo. Baba akasaklini baba ubhizi ngamaphesheni. Manje asazi ukuthi kumele senze njani. Futhi ngelanga sogcina vele sesingasayi. Ngoba noma uthi ngelanga ngathatha usisi wami ngithi ayo test. La testa khona bahleli bawu3 uzokhuluma kanjani kuyo yonke inkinga yakhe. Bawu3 ene uyi1 untombazana odelelayo lapha eCindi. Ukuthatha kwangathi wena awuphila ngencondo. Ngiyabonga.
She's a patient at Main Cindi Clinic. I'll try to be brief and summarize what she said because I was not ready for this. She's saying that at Main Cindi Clinic there's a problem of attitude from all the staff, including the cleaners. When you get to the consultation room, you find 3 nurses and they are just talking their own issues. As a patient, you don't have any privacy. Even if you have a problem, you want to ask something about your health, it's not easy. And every time when they go to the clinic, they are not comfortable because they are not treated with the confidentiality that they deserve. One of the other things she said that as a woman, she has to leave the house early around 4 o'clock, and sometimes there are no taxis, then she has to walk, meaning she has to risk her life to get to the clinic. And then she'd wait at the long queues. That resulted in her stopping her treatment for 3 months. But then one of the nurses then encouraged her to say, listen, it's your life, you're going to die if you're not taking your treatment. But basically, she is not happy about the treatment in the clinic. Thank you.
Always uma ngiyakhona ifile lami abayitholi. Every day bahlala bangibhalela liphepha leli file elisha. Uye ngale phakathi kulabonesi baphindze bathethise wena ngazi ukuthi ngolo sebenza emafayilini. Bathi ifile lakho abalitholi na kwende njani. Uchaze ukuthi ngale bakutshela ukuthi ifile abayitholi. Since ngaqala kunatha amaphilisi nengadi ngiyathatha angitati vele nje nokuthi ngimephi. I-viral load yami angiyathi nokuthi or ngiqhubeke nginathe or ngiqhubeke nginganathi and labanye laba ngithatha nabo amaphilisi sebabachintshile banathala lamhlophe ekseni mina solo ngibamba 8 o'clock lo pink angathi or nami kufuna ngichintshe or ngingachintshe 2019 ngaba pregnant bangithatha futhi igazi event esibhedlela bangithethisa ukuthi anginama results ngabatshela ngathi ifile lami bathi lahlekile nemntwana nami bamthatha ke igazi la esithendeni una 1 year manje asathi nje sinalo mntwana ukuthi simephi ngimane ngiyagunya nje ngiyamgunya akukho nje mntwana la kudlako yena ukuthi ngibone ukuthi or uphilile or nami ngiphilile ngiyaqhubeka nje ngiyabonga.
Okay. The community member is a patient at Extension 4 Clinic, Extension 14 Clinic in Embalenhle. She started taking her ARVs 2 years back. She says she doesn't know the name of the treatment that she's taking. She has her fellow friends saying that their treatment has changed to they're taking it in the morning. But because she doesn't have any information of the kind of treatment she needs to take, she doesn't know her viral load. They regularly take her bloods, but she never got any results back. So she's just taking her treatment. She sometimes have a mind to stop the treatment because she doesn't even know if the treatment is working in her body. She also added that she's got a daughter that is 1 year old that was also tested for HIV, but she was never given the results to say what is the status of the child. And that is making her worried because she doesn't know if her child is infected with HIV or not, or if there's any treatment that her child needs to be taking. Thank you.
So, here are the recommendations. Release provincial health, human rights for health plan by end of June 2021. Include comprehensive list of current vacancies and fill all vacancies outlined in 2021. The second recommendation, enforce National Department of Health circular to open all facilities from 5 a.m. to 7 p.m. on Monday to Friday, and also at 8 a.m. to 4 p.m. On Saturdays. Recommendation number 3, undertake an audit into gaps in staffing. This includes where staff shortages are a barrier to extending opening hours in order to develop a turnaround strategy by the end of August 2021 to prioritize staffing needs for the next financial year. The last recommendation is to please establish and maintain functional filing system and ensure all files are kept confidential. Where space or infrastructure challenges found, develop a turnaround strategy by end of August 2021 to resolve these problems.
The next group of issues are on infrastructure. Most clinics reported need more space for something. These varied across districts, with 72.2% needing extra space in Gersibande district and 100% of clinics needing something extra in Ehlanzeni as well as in Enkangala district. Most commonly, 21 facilities need more space for filing systems. 26 need more space for patients to wait. 21 more need room for medical care to consult patients. Toilets were frequently reported as being in a bad condition. Mostly, toilets did not have toilet paper or soap to wash hands. 25 had no soap and 21 had no toilet paper. But there was also a high proportion of reports of toilets having no water or light or being dirty or broken for patients to use. It is a basic requirement for clinics to have a functional toilet at the clinic, with community members having the ability to wash their hands afterwards. The Department of Health should prioritize getting all toilets into a functional state. Now we will proceed to community stories. Again.
Sambona, ngicela ukungazisho igama lami. Mina ngiyi-community health worker. Ngilapha e-MN Qindi Clinic. Okokuqala nje ngikhala ngakho, singabasebenzi. Sithi masifika ekuseni, asinandawo la ukuthi sizokhona ukubeka insiza zethu ikhwama. Sima ngaphandle noma ngabe liyashisa noma ngabe liyana, siyema. Noma ngabe bathi sifuna ukudla, sinasithenga ukudla funa sidlele ngaphandle. Nawuthi ungena ema-boardroom, bakutshela ukuthi indawo yabantu abakhulelwe. Masiya ngale la kubanjwa khona i-meeting, sitshelwa ukuthi sibanga umsindo siphume. Kodwa basitshela ukuthi saphuma kuma-NGO, sikuma-Department of Health, but still sibona ngathi sisase kuma-NGO ngoba abasitreat as basho njalo. Kodwa nabafuna imisebenzi bayakwazi ukusithuma ukuthi sihambe siyolanda ama-patient ngaphandle siwalethe la. Noma ngabe sesifika ngaphakathi asibonwa nje thina ukuthi kahle kahle sikuphi. Nethi bachaza ukuthi nesinikiwe i-inform yinhle. Siyakubonga lo basinikile but abasitreat as nathi singabantwana babafazi abanjengawo. Sisebenza thina ukudlula bona ngoba bona bahleli lapha ema-clinic. Thina siyaphuma siphume ekuseni sibuya kushona kwelanga but abayiboni imisebenzi yethu. Sometimes nabathi asambe siyofuna ma-default siyawathola. Njengami ngike ngacishe ngagwaza i-default. Yasothi ngasole ngimnyanyisa solo simbizele ema-clinic. Kanye nale staff attitude. Bane attitude kakhulu ngisho kuyithi. Hayi nakuma-patient ngisho kithi bayasithwensa angazi ukuthi yini le ingaka thina esabenza yona. Please, ngicela nangabe khona la nizosisiza khona, sisizeleni kula ma-clinic siyasha kakhulu. Ngiyabonga.
So, she's a community health care worker. The issue it's resulted, it's in relation to the clinic where she's working in Mtonjeni. She said the infrastructure is very small. Themselves as community health care workers, including patients, they wait outside. Even if it's raining or it's cold, they wait outside for long. And the nurses are also giving them attitude. They do not regard them as people who are there to support them. And that is very painful for them.
Thank you. So the recommendations are only two. Clinic cleanliness must be improved. All clinics must have adequate numbers of cleaners to ensure clean facilities and toilets. Secondly, the department, in conjunction with the Department of Public Works, should strengthen the infrastructure unit to address the backlog maintenance, routine maintenance, and the building of the new facilities, and to prevent any unnecessary under expenditure of the health infrastructure grant. So now we are going for stockout shortages of medicines.
Okay, so the next issue that we're going to be looking at is in stockouts and shortages of medicines. So stockouts and shortages of ARVs, TB medicines, contraceptives, and other medicines cause disruption, confusion, cost, and can be detrimental, have a detrimental effect on treatment and adherence. 10.7% of patients we spoke to reported that they or someone they knew had left the clinic without medication they needed in the past 3 months. Here are the highest number of patient reports of shortages and stockouts, with as many as 11 reports at Mangweni CHC and 7 reports at Mpumelelweni CHC and Thembaletu CHC. Facilities also reported stockouts as well, so we look at this from a patient perspective as well as a facility perspective as well, and the highest reports were of ARVs and contraceptives. Here we can see the specific types of ARVs shortages reported. 4 clinics reported efavirenz-based regimen shortages. 2 clinics reported dolutegravir-based regimen shortages, and 3 clinics reported shortages of Dumiva. 7 clinics reported ritonavir, and this is extremely concerning. Of the facilities that reported stockouts, 21 clinics gave patients an alternative, 15 gave patients a short supply, but 4 sent people with home empty-handed. It is critical that the department works to rectify these challenges. Going forward, we will bring this information to the attention of the department at district and provincial levels in real time to assist with the rapid correction of these challenges. We're now going to move on to our community stories.
Sanibonani. Angengithanda ukuthi ngizisho igama. Mina ngike ngavelela inkinga, ngaba nenkinga, ngihamba extension 14 clinic eMbalenhle. Ngo-2019 ngaba pregnant. And this is so ukuthi ngibe pregnant ngangipreventa for 9 years. And umjovo ngaleso sikhathi baloku basijikisa bathi umjovo awukho. Umjovo awukho ngahlala mhlambe 3 months ngingaprevent. Emva kwalokho ngazithola ngipregnant. Mangiye clinic ngiqala isikali bengidla vele treatment, ngiprege ngidle treatment. Sister zangiphathe kahle ngoba wangitshela ukuthi ngiprega kanjani ngidle treatment. And ngamchazela ukuthi mina bengiprevent and kwenzeke so. Emva kokuthi aqeda ukukhuluma ngami waphuma la wayofundisa ngale. Makafundisa okay azange azathi lo sisi lo angikhombe. Kodwa ngendlela afundisa ngayo ngabona ukuthi ngoba uqeda ukukhuluma nami ngapha and manje sekafundisa ngani. Laba abanye abantu bazongibuka kanjani. Kusho ukuthi bayakhona ukubona ukuthi bayakhona ukubona ukuthi mhlambe uyilo sisi lo istory salo sisi lo wayaqeda ukuphuma lo sisi qeda azositshela ukuthi siya prega ngapha sidla ama ARVs asibona ukuthi impilo yethu sengcupheni kangakanani. Ene lokho azange kuze kungiphathe kahle. Hambisa umntwana isikali, umntana mseyavelile athi umntana mayi akakhulu kahle akanamzimba. Angazi vele ngoba vele emncane emzimbeni. Lokho azange kungiphathe kahle. Okunye ngama CH, ngeke ngaba iCH khona lapha. Lokho engikubonela usisi bekakhuluma into eyenzakalayo. Thina basinika ama mask eclinic. Abafuni bavele bakubuza ukuthi usebenza kuyipi organization. Bathi tshelana umphathi wenu. Ngaleso sikhathi uzophatha ikhula box engaka and yasinda. Uyongena ifield ekseni ngo8. Mele uye eclinic ngo4 and stats basifuna every day. Manje mawungana mask awukhona ungena egedini mele uyiwashe uyiphinde. Mina vele isikhathi esiningi bengivama ngifake yona le. ngathatha 2 ngelinye ilanga bangilwisela ukuthi ngithathe kanjani ngoba lama mask lawa wabo sister and ngathola bekiwe ngathi mina nginamask ngazi ukuthi ngelanga sithatha 2 vele thina bangilwisela lokho vele ama CH abawaphathi kahle awunayo nendawo yokuhlala uphathi ibag nje uhambe ngo8 ubuye ngo4 istats basifuna every day vele nje abasiphathi kahle ngiyabonga
Story of shortages of contraceptives. She was going to the clinic around 2019, where she was turned back. She was told there was no injection until she got pregnant. And when she went back to the clinic, they tested her. They found that she was pregnant. The nurse at the clinic shouted at her, saying, "How do you get pregnant when you know that you are HIV? You're not taking care of yourself," and that caused her pain. When she gave birth to her child and she's taking her child to the clinic for antenatal care, she was told that her child is not growing well because she's HIV. And also at the same time when she was consulting with the sister came out to speak to other patients that were waiting in the waiting area, start to educate them that you are living with HIV, you are HIV positive, how can you be pregnant? That means you don't take care of yourself, and so forth and so forth. And also she added to the story that was shared earlier, that she used to be a community health care worker as well. And she has experienced the challenge that they're not given masks at the clinic, they are not prioritized, they're not given PPE. She has to repeat the same mask that she's wearing, she has to wash it every day, and also they work from 9 to 4, they work under pressure, they are expected to deliver, but they are not given resources.
And now we're coming for recommendations. One is we need to ensure that supported districts are adequately stocked by supporting the supply chain at the facility level. The second recommendation is strengthen supply chain monitoring tools, such as stock visibility system, allow for public monitoring and problem identification in a transparent expenditures manner. So now we are going to art continuity.
We are pleased to see an increase in the number of PLHIV who are reporting a 3-month supply of ARVs. However, 9% of people living with HIV still report less than 2 months supply of medication. Just under 60% of PLHIV interviewed through Richidze received less than 3 months of refills, compared to only 21% of PLHIV supported by PEPFAR in other countries receiving less than 3 months. Between July and September 2020, of all PLHIV supported by PEPFAR in other countries, 20% of adult men and 19% of adult women received 6 months of ARV refills. Yet only 0.5% of Richidze respondents reported receiving a 6-month supply, compared to other PEPFAR-supported countries. Here, we see the clinics with 4 or more PLHIV reports of 1 month supply of ARVs. While some PLHIV could be getting shorter supply due to clinical needs, this was not the case at all these sites, where people living with HIV report 1 month of less supplies. The department and district support partners should investigate these sites to see why so many people living with HIV are reporting less than 2 months' supply to rectify this challenge immediately. A key takeaway with adherence clubs seems to be that people are satisfied with the adherence clubs. This is good evidence that we need support for more functional adherence clubs. However, many clubs have stopped during COVID-19. Of those not in clubs, 75.8% of people living with HIV were not aware of clubs, also pointing to the closure of clubs during the COVID-19. We should be thinking of innovative solutions to ensure PLHIV's safety from COVID-19 infection, while also ensuring access to peer support and treatment literacy information. For instance, smaller clubs or outside meetings where there is confidential space. These graphs show that most people, 96.6% to be exact, are getting a viral load test. However, many do not really know what that means. Only 76.9% of those people said healthcare workers had explained what the results mean. The top 2 slides are the results from when we asked people on treatment if these statements were true. Only 82.7% agreed with the statement. Having an undetectable viral load means the treatment is working well. And only 62.2% agreed with this statement. Having an undetectable viral load means a person is not infectious. The U equals U message is clearly not reaching everyone. We will now proceed to a community story.
So ndafika apha eMpumalanga ndahamba kaBhokweni eclinic. KwaBhokweni ndabaxelela into yokubana andikwazi ubuyela eback eGermiston because kukho le lockdown. Bathi bazondenzela ifile ukuthi ndithathe apha, ndabaxelela into yoba ndisenzohlala apha andisabuyela eGermiston. So bathi bazondenzela ifile, ndathatha apha ipilisi bandinike. Ndaya ngedate yam, idate yam ibizi-11 zikaNovember. Ndaya ndayothatha amapilisi. So kwafumaniseka ukuba umntana kasisi wam usuka eJoburg apha. So kwafumaniseka ukuba ndifuneke ndiyozolanda yena apha eNelsport etown. Ngoku ke ndabaxelela into yokuba ndizobuya ngakusasa, ndicela babambe ifayili yam. Sabandixelela into yokuba ifayili yam abayiboni. Bathi mandibuyele apho ndivela khona kwakuqala, abandinika ipilisi.
So from nge-11 zikaNovember 2020 up to manje ngoJanuary awukatholi amapilisi.
Ndizamile ubuyela ekliniki but la sister le bendigcinise kuyo ifile ithe maniqale phansi ndihambe ndiyele apho ndihlala khona ndiyoqala phansi ndize ne-transfer. Ndabaxelela ukuthi andisebenza namali. So ndabuza ke mna ndenze ntoni, bathi abakho nto bazoyenza ngam. I-card number yefile ndinayo. Ayindiphathi kakuhle sisi kakhulu, ayindiphathi kakuhle. Andibi right, ndihlale ndiyicabanga nje ukuthi impilo yam, because before ndidle ezipilisi baqala banditrayina bandixelela ukuthi if uziyekile ezipilisi wadefaulta awuzuba right ngekwempilo. So ayindiphathi kakuhle, ndicinga nalo ukuthi sendidefaulthe ixesha elide. Emzimbeni kona andiluzanga iweight but kunama-shingles rush endinawo. Nincede bosisi and then niyokhuluma namanesi ukuthi noba angandiqala phansi andithathe igazi and then ndithathe ipilisi bandinike ipilisi ngoba andisazobuyela eGermiston apho bendithatha khona sendizohlala apha eMpumalanga.
So we are going for recommendations. Recommendation number 1, extend and implement ARV refills 3 to 6 months supply for all eligible patients. Retain the government gazette 12-month art scripting and implement the March 2020 revised standard operation procedures on repeat prescriptions collection strategies with fidelity. The department and district support partners should discuss strategies with Richitsa Project and the people living with HIV sector on ways to restart adherence clubs safely during the COVID-19, including options for making clubs smaller in size and meeting outside. So we are prepared to work with the department and district support partners. So now we are going for tracing and rearranging of people living with HIV. Sorry, I have another second slide. The department and district support partners should scale up and community-based adherence clubs so that there are clubs available at all clinics and that 20% of eligible people living with HIV voluntarily decanted in this model. Healthcare workers, including Department of Health staff, implementing partner staff, and community healthcare workers, provide accurate and easily understandable information on treatment adherence and the importance of an undetectable viral load when talking to people living with HIV through consultations, counseling, and health talks at clinics. Viral load test results should be properly explained to all people living with HIV in a timely manner. So we are going to tracing and rearranging of people living with HIV.
Chair. So now we're going to look at tracing and re-engaging people living with HIV. Other challenges for linkage and retention are found from linkage officers and community healthcare workers. A lack of phones for the linkage officers and a lack of transportation remain a big challenge to finding people living with HIV, as well as ongoing issues of wrong numbers and wrong addresses that are given by those who are living with HIV. 27 PLHIV we spoke to who had missed an appointment said they were not contacted by the clinic when they do. This is quite worrying because we have the site level data where this is happening and we can provide this to the department and the DSPs in order for them to kind of find out what's going on and why are people not coming for treatment and not re-engaging to care. Poor staff attitudes and unwelcoming services remain a key challenge that mean people living with HIV have stress and anxiety about going to the facility or going to the clinic or stop going altogether. For example, only 48.7% of patients thought staff are always friendly and professional at the facility. Of the PLHIV we spoke to who had missed an appointment, 32 said that they were sent to the back of the queue the next time they came for a visit. 10 said that they were reprimanded the next time they came. We know the worst performing sites are within Tlazache 6 Clinic, Lillian Mambagazi, CHC, Paulina Murapedi, and Imbalentle, CHC. So for instance, where PLHIV we spoke to reported being shouted at or being sent to the queue, these are the facilities that we had quite a number of reports from. Psychosocial support is a critical element to ensure long-term retention and viral suppression and to prevent treatment interruptions. As we know, there continues to be a high number of people disengaging from care, and cases of people becoming treatment fatigued, stopping ARVs, and ultimately passing away. Richidze data shows that 10.7% of patients living with HIV do not have access to psychosocial support, and a further 15.9% who do not know if it is available in the first place. Then we dig deeper into actually what is available at the clinics. So while the pre and post testing as well as individual counseling seems to be widely available, things like patient navigators, support groups, and food parcels are not available. Some support groups, for example, have regularly been committed to by PEPFAR, yet on the ground, we don't see that. So on the graph, we see that 26.6% of people living with HIV report psychosocial support is not available. And where it is available, it's not the full package. So we're now going to go into our recorded community stories that were collected in the communities of Mpumalanga.
Ephumela Mbrapeli ngeke ngahlukumezeka kakhulu ngathola umntwana 2017 ngaba nenkinga ye-operation yami yadabuka ngathi operation yami yadabuka kumele ukuthi ngibuyele e-hospital ngahlala kubhizi bestisha vele belungisa ngathi mangihleli 2 months aphela amaphilisi engangize nawo ngiphuza amaphilisi eRalvis aphela amaphilisi ngathumela umuntu ukuthi angilandele baba badwa bami bathi bafuna mina straight. Okay, waze kwathola ukuthi vele ngihlaleke vele esibhedlela base basinikeza bona amaphilisi ngathi mangiphuma kahle yonke into ihambe kahle abhlungu wenza ngami example bathi nabona abantu abayuseless abangafuni ukuthatha amaphilisi in nganje wangikhulumela vele amagama abhlungu ngagcina ngahluthuka ngaphuma lapho ngahamba ngaya kanjalo treatment kukumanje ngaphuza amaphilisi ubaba kami uyawaphuza ngiyaphuza nawakhe nabantu abawaphuza engibaziyo la ama friend maye ukuthi asele asalayo ngoba kuba khona ukuthi asalithothi inyanga iphakathi banginikeza la umafa khona ngaphuza kusukela 2017 18 19 20 21 manje ububhlungu vele kakhulu ngoba phela negazi angidonsi angizazi ukuthi isinto efocant yami ihamba kanjani yebo and manje abanye sebanokuthi abasawaphuza ebusuku yabona sebaphuza ekseni ngifuna ukuthi ngibuyele eclinic and then uya nje ubizana ngelima yibona amagama nje abhlungu silima phakathi kwabantu yayibona azokwenza example uthothi the secret thina abanye siyafihla ukuthi siyawaphuza lamaphilisi akekho wonke umuntu owaziyo siyafihla i-secret yami ngisho senzoba namahloni yabona kanjalo vele ngeke kusakhona ukuthi ish bazothini yayibona ngifuna nje neduku ukuthi akhula ngifuna ukwenza nesi ngifuna ukuthi akhule ehlise le nto yakhe kuphela cha amazwi umuntu asiphathe kahle amazwi umuntu ngoba nathi siya lapha ngoba sinakho suye vele sidinga usizo serious nesiye lapha sijabulile sami sokujabula nje so sidinga isizo vele sifuna suye venda ukuthi sisize kangisho hayi ukuthi siphoxeke
ngihamba eKemvi Clinic isizathu sokuthi ngize ngiyelena ngathola ukuthi service yalana ayikho kahle kanti ngangiphatheke kakhulu ngaze ngafika lena ngayithola iservice ukuthi hayi ngathi ingconywana eKemville kusahamba kahle noma khona nje bese baba nokuthi babese basicwasa ke ngendlela abenza ngakhona basicwasa ngokuthi thine bantu thine esilanda amaphilisi lawa okugula lokhu HIV basibeka sodwa kuthi laba ababantwana nabagulayo nabakhulelwe bababeke bodwa and then thine bese basibiza ngamagama thine esilanda lamaphilisi ukuthi simnandi manje thine lokho kusiphatha kabi ngoba sesibona ukuthi manje thine kusho ukuthi mabasihlanganisa nalabantu laba kusho ukuthi ngathi sesizobathelela okungcono ngabe siyahlanganiswa uma kuphuma ifayela ngizazi mina ukuthi okay ngiyongena kulo yamnyango loyana ngiyoconsulta khona ukuthi ngiyokwenzani singahlukaniswa ukuthi mina sekuyazi ukuthi ngoba ngihleli lapha yana ngiyothatha amaphilisi aso mina senginokugula okuso yiloko nje okubhlungu nokuthi masifika ekliniki sima ngaphandle noma ngabe kunomoya noma ngabe imvula iyana sima ngaphandle bafike ngabo 7 noma uvuke ngabo 4 uzungene ngabo 7 bakubhalise lapha yana kuyangenza ukuthi ngicabanga ukuthi ngingafuni ukubuyela ekliniki kodwa ke ngiphinde ngicabanga ukuthi ngoba manje lento engiyoyifuna lapha yana impilo yami ngisale ngibekezelela lokuthi at least mangitholile noma inhliziyo yami seyibhlungu at least mangwatholile lamaphilisi angisenendaba
Pole Murapeli bengisebenzisa yona before ane bethatha khona ama-ARVs then until la kwafika khona isikhathi sokuthi angidisclose phambi kwabantu ekliniki then wangitshela ukuthi nini ngidla amaphilisi mara angitshintshe solo nje then nasho sesiyaqabana yabona ngicabanga ukuthi kugcina sekufika ezandleni then ngidecide ukushintsha ikliniki ngasengisebenzisa extension 14 then ngase ngayitshintsha ngihamba ngaye 14 2017 ngaqala ukuthatha 14 extension 14 bebaba baningi kakhulu yangenza ngafila small kakhulu because like you understand ukuthi bengakafeel like ukuthi like ngiready for ukuthi mhlambe ngingatshela abantu usebo ngisetha samsi kanjani attitude kakhulu yamanesi towards ama-patients ayikho right abakwazi ukuphatha abantu ba-rude you understand like baya like 2 to 3 hours elunchini but you'll banama-rights ukuthi baye elunchini understand ngalo mzuzu ufika ngo-7 ekuseni uphuma ngo-4 awutholanga medication awutholanga next kuningi kakhulu nje beyipolela Murapeli no angisabuyela ngiyafisa ukuthi bayitshintshe for abanye abantu because abantu abaningi bebasebenzisa yona yabo yeah mina ngisabuyela vele because ngi-right extension 14
igama lami ngumdora ngwakambila egujwa nasifika amaphilisi basinika kahle nedi ngingayaminye basitshintsha olenye inyanga bakunika lo nyalo asathathe egujwa sebasitransfele kwaChikuru kaChikuru uthola lele bakunika wona ukhona ucomplain ukuthi lawo akuphatha njani wena ngile nyalo ngeti4 kaJanuary uma basinika lawa la pinkish nawufika bakunika nyalo sebakunika la lamhlophe ungaqala unathela lamhlophe yagula ngoba kuqala banginika lawo lamhlophe nganatha 3 ngeva amakhada ngiva konke ngiva amakhada ngathi nangithi ngiwabisela le bakunike la mhlophe uma ubuda ukuthi inzaba bakunike la mhlophe bathi bona lama company ahlukene ngiyo lenzaba nabo babanika kona lokho ngiyo lenzaba basinika lokhu thina nathi mina ufuna ngitibutele bona bangitshintshi akungiphathi kahle ngoba sometimes mina ngiphila ngalokuthi ngiyadiwashela lamakhaya abantu uma lo mtimba sowubhlungu ngicabanga ukuthi kwenenge lamaphilisi lesengiwanatha asiwo lalavana nemphefumulo wami angithi ngisaba lokuthi bathi ungathi uyekela utofu usaba nalo complain sasaba vele complain adothi ucomplaina kakhulu ngagcina bathi akunika lamayela tovuvukisa sibinza what
ngicela ukungazisho igama lami ngihamba eCindi kliniki kuthe ngelinye ilanga ngiya ekliniki ngathi mangifika ekliniki okay ngabanika ikhadi lami lokuthi bangikhiphele ifile balicinga ifile lami bangalitholi ngiyacabanga ngahlala i-hour ne-30 minutes so ngilinde ifile bangalitholi ngathi nangibuza labakhipha amafile ukuthi kanti ifile lami liphi bangitshela ukuthi ukube sesilitholile ngabe sikunikile hlala ulinde ngaphinda futhi ngahlala elinye hour bathi nabasuka lapho bathi sizokwenzela elinye ifile ukuthi uthole amaphilisi bangenzela ngahamba ngaya kusister ngathi nangifika kusister wathi usister yena ayikho into angayenza ngale phepha abanginike lona angijike ngibuyele emuva ngifike ngibayitshela ukuthi abacinge ifile lami baze balithole okay balicinga ke baze balithola ke ifile ngahamba ngathatha amaphilisi right kwangabi nenkinga kuthe ngo 2018 ngagulela ngumzukulu wami umama wakhe bekenza umatric ngahamba ngaya samthatha samsesibhedlela Sathi masifika esibhedlela, bathe esibhedlela mele alale enemele kube khona umuntu ozosala naye because imncane. Ngathi ke kumamakhe ngoba phela wena usesikolweni ene manje kumele uyobhala ubhale ku-matric. Mina ngizosala naye kanti kulawo malanga lawo kuzoba ne-date yami ukuthi ngiye clinic. Ngangakhona ukuya clinic because ngahlala iviki lonke nomntwana esibhedlela. Ngaphuma kuyi-Friday, ngathi mangiphuma kuyi-Friday, Monday ngavuka ngaye clinic. Ngathi mangifika clinic, ngalomkhuba wabo ukuthi bathi mawungana date mele mumva bazogcina ngani. Okay, ngaya kubo ngafike ngachaza ukuthi inkinga yami eyenze ukuthi ngingezi eclinic ngedate yami bengisesibhedlela ngimikise umntwana. Bathi hayi sesi asinankinga ukuthi wena bomikisa umzukulu wakho ngoba phela nina nithuma abantu benu ukuthi bahambe bayolala namadoda bese nina niyakwazi ukuthi nisale nabazukulu. Lokho akuzange kungiphathe kahle, kwangiphatha buhlungu. Kwa-endapha bangangisizanga, bangitshela ukuthi either uyalinda siceda ngalaba ama-date abo or either sikunika i-date yokuthi ujike uphinde uhambe ubuyele ekhaya. Engakudecide mina ngoba ngabona ukuthi noma sebaqedile ngalabantu laba bazosola bangidrayisa bangishonisa le nale. Ngadecide ukuthi okay ngicela ningibhalele i-date engizobuya ngayo. Bangibhalela ke i-date ngajika noma sengichaza ukuthi amaphilisi asangiphelele kwafana nokuthi ngiyadlala nje ngithela amanzi omhlane wedada. Bangibhalela ke i-date ngahamba ngaye ekhaya ngahlala ke leyo 4 days ngingaphuza amaphilisi. Ngabuya ngale date abangibhalele yona, ngafike ngadonsa ifile ngayongena ku-sister. Ngathi nangifika ku-sister naye wafike wangithethisa wathi angizanga ngani ngedate yami. Ngamtshela ukuthi into eyenza ukuthi ngedate yami bengingekho mina bengisesibhedlela ngimikisa umntwana. Wathi wangezingane eclinic, ngathi ngeza eclinic plus ngangiphethe nobufakazi lencwadi abadischarge ngayo umntwana esibhedlela ukuthi babone vele ukuthi bengisesibhedlela. Bathi kwafana nokuthi ngiyadlala kodwa ngalelo langa layo date yabo ngajabula ngoba amaphilisi ami ngawathola kodwa leyo nto leyo isesilonda kimi ngoba mina ngahlala amalanga ngingawaphuza amaphilisi ami. Kanti mina ngale time bangikhansela banginika amaphilisi ami bangitshela ukuthi nangebhadi nangephutha ngingawajampisi kodwa ngahlala 4 days ngingawaphuzi nedi ngendaba ye-date. Ngiyabonga.
She's a patient at Emencindi Clinic. Her challenge is that often when she goes to the clinic, she's had an experience where they cannot find her file. And you find that she's waiting in the queue, and when she tried to ask, I've been waiting here and people that came after me are passing, I've not received the file. They respond rudely to her to say, what do you want us to do? Because we told you that we can't find your file, so you need to wait. At the end, they wrote on a piece of paper, but when she went inside the consultation room, the nurse that was attending to her shouted to her to say, where is your file? Why are you having this page? And she felt so bad, as if it's her responsibility to know where the file is. Secondly, when she was assisting her granddaughter who was hospitalized, she was in hospital with the granddaughter for about a week, a grandchild for about a week. She missed her date. When she went back to the clinic after the granddaughter was discharged, they shouted at her to say, you have missed your date, we're not gonna see you. And she tried to explain to them that I was not around, I was in hospital. I was in hospital for my granddaughter. They said, yeah, it's because you mothers teach your children to give birth at a younger age when they cannot take care of their children. And you miss your appointment because you're taking care of your grandchildren. And they did not give her the medication. So she is very hurt because for that time she stayed about 4 days without taking treatment. As she recalls that when she was first counseled about the treatment that she's taking of HIV, she was told that she should not even a single day miss her appointment. And that thing of her missing the treatment for 4 days is still haunting her even today. So what she's saying that the nurses in the clinic are not friendly and did not explain to them properly. They are not talking to them properly.
Sanibonani. Sanibonani. Igama lami nguSithembile Wabuthelezi, ngiphuma eAmsterdam. Iklinikhi engiyisebenzisayo isemthonjeni iklinikhi. Mangisuka ekhaya ngeklinikhi ngigibela nga-120, kumele futhi ngigibele la eMelo ngiye eklinikhi itaxi i-R12. So ngathi mangifika eklinikhi last year ngo-October ngathola ukuthi abantu babavalele igate, so beme iline la ngaphandle, and into engazange izingiphathe kahle ukuthi bemile iline lapha, mabeme iline nathi mele sime lapha, ama-taxi ayandlula la, bayabona nje ukuthi nanoma ubani uye eklinikhi, nanguyaloya uye eklinikhi, and asizazi izitha zethu, ngamanye amalanga bayasithuka ngalokho. Okay, kwenzeka-ke ngoba isekudeni ekhaya, ngaya lapha egate lama-security ngabacela ngathi ngicela ningifake phakathi because mina ngihlala ekudeni, and mangingahlala isikhathi eside lana angeke ngisayithola imoto eyibuyela emuva. Bathi ngispecial ngani mina ukuthi ngizongena ngaphakathi abantu bamile bangaka. Ngathi mina ngiyanicela, hayi kwenzeka ukuthi ngatshela umphathi uLucky ukuthi ngicela ukuthi azongikhulumela nabo ngoba ngihlala ekudeni. Okay, bangifaka, mabangifaka ngangena ngaphakathi. Ngaya lapha e-reception la kukhishwa khona ama-file. Bafike bamemeza lapho bathi laba abamakhadi agreen abeze bazothatha ama-file abo sawakhipha. Obvious wonke umuntu uzobona ukuthi laba abamakhadi agreen bane-HIV. Ayizange izingiphathe kahle lento leyo, and bane-attitude amanesi alapha nje abasiphathi kahle. Okay, ngaya ngale ngafike ngadonsa, ngafike ngapompa, and mabakupompa lapha baningi awukhoni ukukhuluma ukuthi ucela bakusize ngaloku, bakhuluma indaba zabo. Kwathi makusuka lapho ngangena ngale kulo nesi lo, wafika wanginikeza enye indlela net angazi ukuthi la maphilisi abhalwe ukuthini. Ngambuza ngathi la maphilisi lawa ani, wathi okuvala inzalo uzolithatha kayi-1 ngenyanga. Ngathi mina kusho bani ukuthi ngifuna ukuvala inzalo because mina ngize la ngizothatha ama-ARVs. Wathula wangibheka emehlweni nathi ufuna usizo noma ufuna ukufa. Naloko azange kuze kungiphathe kahle, abasiphathi kahle vele emaklinikhi, so besacela ukuthi nisisize ukuthi nisikhulumele nabo. Ngiyabonga.
So the patient uses Amsterdam Clinic. She says her taxi fare to the clinic is about 12 rand. And the transport is very difficult to get. When they get to the clinic, they have to wait outside where the taxis are passing, and she doesn't feel safe. She had requested at some point to enter the facility first because she was realizing that time is going, and when it gets late, it's going to be difficult for her to get the taxi to go back home. But then the response was that, what makes you think that you are special to everybody that is waiting in the queue? And one other thing that she's not happy about is when you enter the consultation room in the clinic, there are 2 or 3 nurses who are discussing their own issues. Even the nurses that is attending to you is not even paying attention. As a patient, you can't even ask anything that you want to ask about your health. At some point, she was given pills. She was told that you must take 1 pill a day in these pills. And when she asked what are they for, they said it's to prevent you to get pregnant. And she said, but I never said I want to prevent pregnancy. And they told her that, do you want to get pregnant while you are HIV? Do you want to die? And also that does not sit well with her. I think I left the last part. Come again? Okay. I'll cut it there. Number 5.
Sanibonani. Igama lami nguLileni wakamahlaba. Ngadiagnoswa 2018 ngithatha treatment ePaul Mrapedi. Okufike kungiphathe kabi uma ngidiagnoswa ePaul Mrapedi. Ngiyeza abantu bakhuluma ngecounseling. Angizange mina nginikeze ucounseling. Engikwaziyo kwathiwa ngiyabona na ukuthi amalani sayi2. So njengoba amalani sayi2 ngatshelwa ukuthi CD4 counter yami ithi 3 in then sokufanele ngithatha amaphilisi immediately without counseling and everything engikwaziyo nje ukuthi nganikezwe amaphilisi lawo maphilisi lawo ngagula uma ngigula angizange ngikhona kuye clinic because njengoba ngisilenda so ngaba silenda more than this angakwazi ukuvuka ngasakwazi ukwenza next sengumuntu olala embedeni then it happened ukuthi ngamikiswa ku special doctor eNigeria. Then mafuna unyemba afuna ukwazi ukuthi yini lamaphilisi hlobo lamaphilisi oliphuzayo like enough because bangitshela ukuthi lo baba wathi ngcono asuggest ukuthi ngcono sambe nawo lamaphilisi uma ngimtshela lo doctor ukuthi bathi nge-HIV wafuna ukwazi ukuthi ngibani othe we-HIV why bakunikele hlobo lamaphilisi ngathi angazi naye wangibhalela incwadi wathi ngimikise clinic yo hayi ngayithela umsobheno onetswayi bogcwalelana ngami babizana laba manesi babizana ngami bangitshela the way ngicabanga ukuthi ngingcono ngakhona bangitshela the way ngicabanga ngihlanyiswa imali ngakhona bangitshela the way ngijima ama special doctors ngicabanga ukuthi bona njengoba bamanesi lapha abafundanga na ngangayelanga lokho but udoctor wabhala incwadi wathi lamaphilisi lawo abanginikeze wona bangixokelile ngawo na ngiyazi ukuthi owani because lento abayibone yena nalento ebona yiclinic into ezi2 different then akunandaba already ngase ngiwathathile lamaphilisi then kwase ngizimisele vele ukuthi nangabe vele kunjalo fanele ngichubeke nempilo okay it happened manje ukuthi is the more manje umuntu aye clinic akunabo mnandi eclinic first of all njengoba ngisho ngithi angizange ngitshelwe ngendlela right azange ngwelcome ngendlela right or nginikezwe leyo counseling yokuthi kuzokwenzakala nempilweni sesihlangana manje kule minyaka le sihlangana nalo mama orude eclinic lasePaul Mrapedi nangaba abantu bayasaba ukukhuluma ngiyacanga ukuthi isithuba manje ukuthi bakhuluma kuno sister lapha bathi uNomsa wakambongo lo mama yasithuka yazi ene okubhlungu sindanga nalabo mama umama nje ongaka ngathi but angazi mhlambe ukuthi le profession yakhe ukuthi yena unesi imnikeza ipower yokuthi atreat umuntu ngale yandlela le yabona le mama loya ongumama uright bobaba yabona bobaba uright kakhulu babamgonya bayazi baphatha kahle bobaba kodwa when coming to abomama angazi mina uhlala ready for abomama uzokutshela ngendlela afunde ngakhona uzokutshela ngendlela angasisidakwa uzokutshela ngabantwana bakhe abafundile abagraduate uzokubiza ngawo uhlobo lonke lo muntu ukwenza ukuthi moye clinic ungasajabuleli le clinic ukwenza uzinyeze ukuyabona umama uyazinyaza and only to find ukuthi umuntu mangase position yakhe asemsebenzini wakhe uyamhlonipha ngithi lento ifana ukuthi uphuma kakho uyaka makhelwane fanele kumnikeza all the respect manje uma umuntu uthi uyamhlonipha uzomloku umkhuluza ukuthi hayibo sister mina angifuni lokho it happened last nyana la sathi sile lapha eclinic sathola ukuthi kuno sister bathi umdu lapha eclinic izulu liyana ufike ngo5 uzohamba ngo4 4 ngakashayi u3 ngakashayi angeke uzohamba kwenzeka ngesikhathi sasenza itoyitoyi nabo babungonya because umphathi walapha ngazora bamsabi or too soft na basinikeza isikhathi sokuthi izofika isikhatsini uyafika wena ngesikhathi sakho itreatment yakho ayitholi nomunye uyafika nomunye ayitholi kuthiwa kune covid akufanele ngasihlangane lapha sibe baningi kodwa lapha embalenhle siyagcwala sibe baningi akuna social distancing and lapha embalenhle lawa ayikho lento yokuthi bathi ngoba naku kune covid-19 i-covid-19 lesesizwa nje la emoyeni ngoba naku ufuna ukusinda na uyawulalela kodwa ayilandelwa lapha sihlala sonke sihlangahlangane ngale ndlela kuhlangana ngakhona abadala nabancane ukuthi abantu abadala fanele bangene ecala or mhlawumbe abagula kakhulu fanele bangene ecala ngoba nakubona mhlawumbe kuthiwa amajinsi abo or amasosha omzimba wabo asanenkinga lapha ePolymerabed ayikho uzomthola lo mama ozokuthuka akubize ngayo yonke indlela manje nangabe khona eningasenzela khona please siyanicela asifune ukubona umshado lapha ngoba umdu wathathenga imoto babenza test driving lapha ukuthi nasifike ngo5 bona bafike ngo8 basindlula la kodwa manje kwalilizelwa lapha kwenziwa i-test driving sabukela manje sengathi manje asinangcondo umbuzo wami uthi uma ngabe sinenkinga ePolymerabed ngibani okufanele simfonele simbize ukuthi azosibonisa mhlambe azosiza ngoba ngempela lapha ePolymerabed lento eyenzakala lapha sesimani siya eclinic for impilo yethu ukuthi sifuna ukuphila kodwa iservice yakhona hayi guys abasihloniphe labantu bayasdisrespecta bayasithuka yazi nje leso staff salapha mina ngisazi so siyanicela njengoba sizoreport ngoba sesizwe ukuthi kungaphezulu kwamahlombe ethu sithola umthwalo esingathi sizothula ubani siyanicela namhlanje ukuthi masizile sizoletha ama-complaint ethu ngathi ngake nivakashela lapha ePolymerabed ngiyeza ukukhuluma ngama-toilet lapha ePolymerabed kunama-toilet ayi-2 okungena bobaba nabomama mani ngayongena lapha usaba nokuya toilet cabanga uma ngo5 lapha tot ngo4 ungayanga kule toilet la ngoba into ozoyithola lapha uthola kuma tissue abomama bazela nama tissue ngoba lapha ePolymerabed akuna tissue yakhona kungcolile ama toilet akhona wa flush mhlambe kunenkinga yamanzi kuhlala kunenkinga nje unhygienic lapha so siyanicela guys nangabe khona into engingasenzela yona akanivakashela ePolymerabed kanizokhuluma nalo mama ukuthi sinele we are enough unless uzositshela ukuthi uzayibuyela uzositshela ukuthi yena waseSwazini uzamela ukuthi ahamba eSwazini ayobheka ayosebenza eSwazini mhlambe ngalo izweni kuba bazobahlonipha ngoba thina ngapha eMpumalanga ngoba sifundanga mhlambe sifunde kancane kuyahlelo ukusihlonipha sicela ngisenze lokho ngiyabonga.
Okay. Loud. She's a patient at Polymerabed. She got diagnosed around 2018. She was given treatment. Her concern is that she was not given counseling. She was just given treatment. She was told that her CD4 count is low, it's around 350 something. Then she had to take the treatment, but she was not told what is the treatment, what it's for, and how long she's going to take it. While she continued taking the treatment, she fell sick, more and more sick. And a family member took her to Nigel, to a private consulting in Nigel, where the doctor wrote a letter for her to say she must give it back to the clinic. And she's saying when she went with the letter back to the clinic, it was like she put paraffin in the fire. The nurses called each other, they shouted at her, they told her how she thinks she's important because she had some little money to go to a private consulting. Secondly, she's saying that in Polymerabed there is a nurse, and as the public healthcare users at that area, they've been complaining a lot about this nurse. The sister in charge is aware of the problem. She is rude, she's insulting them, she calls them all sorts of names, and including the other nurses in the facility, they do not regard the patient. At some point, she remembers one of the nurses had just bought a new car, and they just left the patient stranded, and they walked around test driving the car and doing all sorts of noise and not paying attention to the patient. She's also spoke about the COVID-19 regulation to say they just hear outside in the news and everywhere that there's COVID, they must social distance, they must do what? But in Polymerabed, that is not happening. Because they want to get treatment, they go to the clinic, they are filled there, they are packed, they arrived around 7 and only leave at 4. And there's nothing they can do because they need to get treatment. At some point, you can even leave the clinic empty-handed without getting your treatment. So she's re-emphasizing that she came here wholeheartedly to report this, to say they really need somebody to come and intervene at Polymerabed because all the community, the public healthcare users knows the problem that they have in Polymerabed, and it seems as if they are struggling. of this particular healthcare worker that is disrespecting them. And yes. Oh, I forgot hygiene.
Sanibonani. Ngicela ukungazisho igama. Mina ngibuya eMbalenhle. Ngiye ngasebenzisa iklinikhi le yase Paulina Mrapeli. Iservice lapha yana ayikho right. Ngoba uyafika lapha yana ekseni uthola ukuthi nizolinda isikhathi abonesi bayafika baqale ngento zabo kuqala kuze kushaya bo9 bangakanisifi. Mara isikhathi somsebenzi siqala ngabo 8. Mase sebaqala ukusebenza basiloli nakhona. Bayasebenza baphinde banishiye baphume bahambe. Babuye baphinde baphume bahambe. Mabasuka lapha banitshela ukuthi bona bakhathele. Bese uyazibuza wena ukuthi mabathi bakhathele wena kumele wenze njani? Futhi kumele ulinde until baze baphumuleke bona babuye futhi bazonikeza amaphilisi. So ngadecide mina ukuthi le clinic le ayingiphathi kahle ngoba ngiyabona ukuthi ishi ngizogcina sekhuluma nabo nesi ngendlela engekho right. Yabo sesingasahloniphani. Ngayichintsha ngaye station 4. Hayi ngafika khona ku West kakhulu. Hayi e4 ku West kakhulu. Ngoba e4 ish buthi uyafika ifile awulitholi. Bayolithola mhlambe ngabo 3 ntambama. Wena ufike kuqala leso sikhathi sebangakho abantu abakudlulile. And mabalithola la ifile lakho ngeke bathi wena ifile lakho bophambili. Bazokuthatha bakubise bakutshela ukuthi buya uzohlala la. Uyophuma ekugcineni ufike kuqala. Yabo. Uphinde uye nangakusasa ungalitholi futhi file lakho. Uzibuza ukuthi hawu kanti ifile lilahleka kanjani mawuphinde ubuye ngedate yakho. Ngoba balitholile la. Babuze wena futhi ukuthi wena ulishiye phi ifile. Watshela utani mina ngithe mangiqeda ngaphakathi liyasala ngisho ifile vele lapho mawuqeda ukunikeza amaphilisi. Bona bese bayalithatha. So iservice yama-clinic wethu eMbalenhle awekho right. So ngasho ukuthi hayi ngcono ngiyeke vele eMbalenhle sengithatha treatment eBhetali. Kungconyana. Ngoba ngisuka eMbalenhle ngize khona ngifike ngithatha i-treatment ngaboma 1 sengisembalenhle futhi. So mina ngibona ngathi futhi ingcono le yala Bhetali. Ngiyabonga.
Taking treatment at Paulina Mrapedi. At Paulina Mrapedi, there's a problem that you arrive at the clinic in the morning and you'll be told that they can't find your file. And you'll have to wait, and when they eventually find your file, a lot of people have already passed. And there's no way that they'll tell you that since you were here and it's our fault that you can't find your file, go in front. So you'll end up leaving very late. And at some point, they even asked him, where last did you see your file? Where did you leave your file? And his response was that, but I left the file in the clinic. And when he realized that he was not happy about Paulina Mrapedi, he decided to go to Extension 14 clinic. He said, Extension 4 clinic. He's saying Extension 4 is worse than Paulina Mrapedi. There, at some point, he doesn't get his treatment. The waiting time is even longer. So it was worse than the first clinic that he was attending. Then he decided that he's going to go to Bethel. Now he's taking his treatment at Bethel. At Bethel, he's saying that the service is better. At least he will arrive there in the morning around 7, and around 1, he will be back home. Thank you.
Sanibonani. Ngicela kungazisho igama lami. Mina ngisebenzisa iclinic yaseMthonjeni. Ngiqale 2015 ukusebenzisa iclinic yaseMthonjeni. Ngithe mangibuyela 2017 ifile lami lokuqala azange bathi abasalitholi. And umniningwane wami wonke ukule file lokuqala ne kose ngesibhedlela esithombeni kwesibhedlela x-ray. Mangifika esibhedlela ufune babuze kimi ukuthi kwenzakalani ifile alikho. Mangibuyele eclinic bangibisele eclinic eMthonjeni. Nangifika eclinic eMthonjeni ngibachazela ukuthi esibhedlela bafuna okubhalwe lapha efayilini. Uneso engamthola eMthonjeni ngiyangimusha igama. Wavele wathi angisho wena uyazi ukuthi kubhalweni. Gula mina noma kugula wena na. Ngabuza ukuthi mina ngikhulumile engiphethwe yiko la ukuthi ngiphethwe yini. Nabhala nini? Lokho nikubhalile fune bayakufuna lena mina ngikuthi angizange sakuthola. And then okunye ngathi mangibuyela ngo-2020 lonyaka ophelile ngangasalithola ifile ngadecide ukuthi ngiyeke eclinic ngahamba ngawoqala iclinic eDondoni and nomntanami futhi kanjalo naye uphethwe isifo sokuwa clinic eMthonjeni uyaya bangamnika amaphilisi bathi amaphilisi akhe ayashoda abakawathumelanga esibhedlela manje ngase ngicela ukuthi okungcono ahambe ngicela itransfer ukuthi bamtransferele eDondoni eclinic kungcono kakhulu ngoba nakafika khona amaphilisi wonke wathola khona uyawathola amaphilisi uyakuthola konke akufunayo and then la clinic eMthonjeni bebangamniki umntanami uzulimele angisebenzi okokucala uhamba ngetransport ukuyelanda amaphilisi eDondoni angisebenza akanaba babakhe washona umntwana na 17 manje una 21 soludla amaphilisi mara usizo angilitholi mangizela eMthonjeni itransfer ngiyithathile kulenyanga ephelile beka solo ngiza ngilanda naseDondoni nala khona la eMthonjeni ngathatha itransfer kulenyanga ephelile nge11 nge11 lenyanga ephelile ngathi ngithathela itransfer ukuthi vele okungcono sala iyeka la eMthonjeni ngoba amafile ayalahleka ene bonesi abasizi ngesikhathi esifanele bonesi bayafika uthole baphuma bangena ungazi ukuthi benzani umntwana uwile lana wakhona egateini eclinic ama security amthatha amfaka phakathi bafike phakathi bangamsizi kwakose ukuthi ngihlale naye mina emabhangini solo ngishift emabhangini bathi angilindi line uzolinda iline umntwana ulimele lana ukuwa akusimnandi ukuwa komntwana ngoba awazi ukuthi makawa kwenzakalani kuye ene wayiluma lapho wayiluma ilimi isandla sakhe sathinteka namanje isandla sakhe asisebenze siyi1 angisebenzi ngicela usizo ukuthi eMthonjeni ake nizame ukukhuthaza amane saseMthonjeni ukuthi akayeke ukwehla enyuka ngesikhathi somsebenzi awangena emsebenzini asebenze ngabantu umuntu makangena limele mabamnake noma makangena afuna itreatment yakhe awa noma ugula ngalenye indlela abazame ukuthi basukume bamsize banisikhathi sokwehla benyuka baqoqe bahleke uthi nawuthe bakhulumisa bathi bona bawufundele lo msebenzi wena ufundelanga bachashela ukwenzana abangafuni ukusiza abantu siyacela iclinic yaseMthonjeni ayisiphathi kahle iclinic yaseMthonjeni iclinic yaseDondoni ibetha kakhulu mawufika khona bakubuza ukuthi usukeleni la ubuya khona ufika ungene uthola usizo ngaleso sikhathi ena ushift imali izitulo solushifta nezitulo ufika ngaleso sikhathi noma ungafika ngo7 o'clock 7:30 utholile usizo uyaphuma uyahamba mara asihlali khona sihlala la sikhulele la sithola abantwana khona la sibahambisa la mara sithola usizo hayi iclinic yaseMthonjeni angilibona usizo lwayo noma ingavalwa kungcono sivele sihambe esibhedlela bekungcono khathi siye esibhedlela attend ebusuku ngiyabonga kakhulu.
She's a patient at Mthonjeni Clinic around 2014. That's when, and 15. That's when she started taking her ARVs at Mthonjeni. Around 2015, she had a problem where she was not well. She was referred to the hospital for X-ray. But unfortunately, at the clinic, they had lost her file. So the hospital wanted information that was on her file. And they sent her back to the clinic to go and get the file, the information. And when she went there, she asked the sister that the hospital needs the file or needs the information on the file. And the response from the nurse was that, but who's sick? Is it you or is me? Because you know that what is your problem? Why didn't you tell them? And she said, but everything that I knew, the way I was feeling, I had explained to the nurses. So my expectation is that it's written on my file, and that's why the hospital is asking for my file. So she's not happy about Mtonjeni to an extent that she took a transfer. Now she's using Dondon Clinic. And she's saying that as a person who's unemployed, she has to use transport money to go to Dondoni. She's saying that the service in Dondoni are much better. Everything is quicker, and even the nurses are friendlier than in Mtonjeni. She further emphasized that the way the service are in Mtonjeni Clinic, it's even better for them if that clinic is closed, because they don't see a use. Because a lot of people that are using that clinic have now took transfer to go out to use other clinic. She further make reference to her daughter who's epileptic, who once fell at the gate of the clinic, and the security assisted her and took the child inside. But the nurses did not attend to the child. She was told to wait at the seat. As a result, her child was hurt. She was bleeding in her mouth, and her hand is now not working properly. She's saying that Mtonjeni, they do not understand or prioritize people who are sick. If there is an emergency and a patient needs to be attended first, they do not care about that. And last month, she said she also took a transfer for her child to attend at Dondoni Clinic, which is problematic because she's not working, and now she has to pop up transport money for 2 people to go to Dondoni whilst they are residents of Emelo, because the service at Dondoni is much better and it's quicker.
Angizisho igama. Ninkinga lana okay ngwasembalenhle. Ngwasembalenhle inkinga yami ukuthi angikho happy ePaulina Mrabedi. Ngizobiza igama la nurse lo angenza ukuthi default. Laphayana bekhona inkinga bekose ukuthi ngihambe ngiyoyenza. Ekhaya bengelana nasekhaya bekose ukuthi ngibuyele eklinikhi. Sister Noms. Bekhona abantu simix. Nesekhipha ama-file. Bekhona umnye ubaba wayegula lapha. Wafika wathi kimi mina wayengezanga. Ngamtshela ukuthi ayikhona inkinga bengisayilungisa. Wathi uyakwazi lokuthi uzogula njengalo baba lo ufe. So wangenza ukuthi ngizizwe ngimncane because abanye abantu abasazi status sami. So yena sekangimbarasa kanjalo. So ngathi sayiduthe ingcono ngiyeke 19 ngihamba iTBK yaseBhetali.
I started my treatment at Extension 19 Clinic. One day, I missed my appointment because there was a family something that I had to attend to. So on that day, I could not go to the clinic. So I missed my appointment for the day. When I went back to the clinic, the certain sister that the first patient spoke about said to her, why did you not come to the clinic on your date? And she tried to explain that I was not around because there was something happening back at home, so I had to go there. And she said, do you see this man sitting next to you? The man was looking very sick and frail. And the nurse said, you're going to be sick and you're going to die. You're going to look like this man in front of everybody. And that made her not to feel very comfortable, because she literally disclosed her status in front of everybody, whilst Yena, she's not even open about her status. So she decided to stop going to that clinic, and now she's going to Bethel Clinic. That's where she takes her treatment, and then she has to use transport to leave Mbalenhle to Bethel to take her treatment.
Sanibonani. Nangoxoxa igama. Ngisebenzisa iPaulini Mrapedi ikliniki. Ngiqale last year ukuthatha ama-ARVs. This year manje ngo-April masiya ekliniki bathi amaphilisi awekho sibuye. Ngahamba mina ngabachazela ngabatshela ukuthi ngiyahamba ngiya Nelspruit esibhedlela. Bathi labo nesi uma ngabe sengibuyile ngibuye ngizowathatha. Mangibuya ifile lami langena ku Sister Nomsa. Nangena ku Sister Nomsa uyangibuza ukuthi indaba angazange ngizolanda amaphilisi. Ngithi mina wena waphuma wasitshela wathi amaphilisi awekho aphelile. And sibuye ngeMonday mina ngichazile ukuthi ngeMonday angize ekliniki ngesibhedlela. Wathi yena wasitshela wathi uma ngabe singathathanga amaphilisi sefastereni futhi ngakhulumi lento enje ngoba yena bangadakwa ngasikhathi akhuluma lenkulumo wasitshela wathi sefastereni. Ngithi mina azange wasitshela mhlawumbe watshela bangakusasa nothi thina. Wathi yena akadakwa akaphuza utshwala ngingakhulumi lento enjalo phambi kwami. Waqeda lapho wathi ngidonsa nini. Ngiyamtshela ngithi ngidonse last month. Vele akusavumi. Kwakungathi ngisukume ngihambe ngoba sokhuluma ezinye izinto engazazi. Wangathi ngidonse kula ngiyaphelile. Wathi ngiyakubuza ngithi udonsa nini? Lento engazazi nokuthi idonsa nini. Okokuqala mina ngiqale last year lona ukuthatha ilokhunjana. Ukuthatha ama-ARVs and azange mina beze bangichazela ukuthi kwenziwa njani. Bathatha igazi nje ngoba vele ngangena esprayed. Bathatha igazi baqeda lapho bathi u-HIV phela nje. Banginikeza amaphilisi. Makasekabiza yena sothi laba abathatha amaphilisi asekuseni awekho amaphilisi asekuseni. Mangimchazela ukuthi mina amaphilisi asekuseni angiwazi niwa late angiwazi. Uthi angidakwa mina ngeke ngikhuluma into engayazi. Hayi base siyayekela kwathi udonsa nini ngathi ngidonse kule nyanga ephelile. Wathi ngiyakubuza ngithi udonsa nini? Ngithi mina balake ukuthi ngoba ngidonse kule nyanga ephelile ngidonsa nini ngoba aningichazelanga mina ukuthi kwenza njani. Uthi ufonela lo mntwana lo sefastereni wamaphilisi. Uthi nikeza lo ongazi ukuthi udonsa nini amaphilisi lapha efastereni. Ngithi mina imaphi lawo maphilisi lawo? Uthi uza kunika lo mntwana uyazi ukuthi imaphi. Manje nangifika kumntwana ngingaka umntwana azofika athi na amaphilisi wakho wena lo ongazi ukuthi udonsa nini. Angazi ukuthi ngithini. Ngicela nimkhuze usister. Ngicabanga nokwayeka nalamaphilisi futhi mina.
She's a patient at Station 19 Clinic in Mbalenhle. Her last statement is said, she started treatment last year. So when they are waiting outside as patient at the queue, the nurse comes and say, those that take treatment in the morning, we don't have the treatment. Only those that takes in the evening must wait. She says when she was given the ARV, the treatment, she was not told what is it. And when she asked which ones are those are taking in the morning and those that are taking in the evening, because Mina, I do not know. I was just given treatment. She gets shouted at. And secondly, they asked her, when do you take your blood? She says, I took my blood last month, but I do not know when again do I have to take my blood. And at that point again, she gets shouted at. And this particular nurse that she spoke about will say to her, go to that window and take your treatment. You don't even know when you're supposed to take your blood. You don't even know your treatment. So it makes her feel so useless about her life. And that to an extent that right now where she is, she feels like just stopping the treatment at all because of the treatment in the clinic.
Yeah, it's so disturbing. And now we are going for recommendation. Recommendation number 1, ensure IPs follow all protocol routine when someone misses the appointment, including SMS, phone calls, and home visit. Investigate any sites where there are reports of people living with HIV not being contacted by facility after a missed appointment to ensure protocols are being followed. The DSPs should ensure that all linkage officers have access to phones, airtime, data, to be able to call people living with HIV who miss appointments. The department with the SPs should work to ensure that community healthcare workers have access to reliable transport and access to PPEs to effective trace people living with HIV who have disengaged from care. A circular should be issued that calls on all staff to treat people with respect and to withdraw to measure that people living with HIV misses appointment should be sent back to the queue, especially NOMSA. NOMSA, I'm angry at you. I hope the department will do something about this nurse because she cannot treat people like that and we keep quiet. Unfortunately, I cannot stand that. I'm boiling where I am. The next recommendation is to address all issues of staff attitude that lead to people living with HIV stopping treatment or disengaging from care, including by investigating all allegations made with regard to health personnel failures, including neglect and bad attitudes. Following this investigation, disciplinary action should be taken where appropriate and compensation be paid out to victims of neglect or ill treatment. So we will follow up with this, especially with Mbalenhle Clinic. We hope that this will be followed and we'll continue to follow up with the Department of Health and see what actions are they taking from the nurses and the treatment, ill treatment that patients are getting in that facility. Often staff do not treat people properly due to stress, exhaustion, and burnout as a result of malfunction in health system, including lack of time, tools, equipment, or medicines. Better staff support system should be put in place by the Provincial Department of Health in order to ensure staff wellness and support. Investigate site with reports of people living with HIV statuses being disclosed. IPs should provide full package of psychosocial support, including individualized counseling to patients, peer-led patients, navigators, acting as a bridge between the clinicians and the patients, mapped networks of referral services, optional support groups, and food parcels. So now we are going for index testing.
It is heart-wrenching and very disheartening to see what public healthcare users have to go through to get the life-saving treatment that they need. Whilst index testing has the ability to help identify individuals who may have been exposed to HIV earlier, if implemented in ways that cause harm to individuals, undermine the rights to consent, privacy, safety, and confidentiality, it erodes communities' trust of healthcare providers. We are concerned that screening protocols are not always being followed. Only 89.7% of clinics say they always screen clients for intimate partner violence. 48.6% who do not screen, who do screen for IPV, still contact all the partners, regardless of reported violence. This is a major concern and a violation of people's safety and privacy. What is the point of IPV screening if contacts are just notified of their exposure anyway? Here we see the PLHIV perspective. 58% of PLHIV were asked to participate in index testing. 20.3% did not think they were allowed to say no or refuse to give the names and contacts of their partners. 29.5% of people living with HIV said there was no intimate partner violence screening. Further, screening for IPV without adequate IPV services to respond to a client's positive screen is dangerous and unethical. Where IPV is reported, facilities should be able to provide IPV services either on-site or by referral. However, 13.3% said they do not offer anything. These facilities include Kanyamazane CHC, Mkwalini Clinic, Nelspruit CHC, Amsterdam CHC. It is particularly concerning that large CHCs are stating they do not offer intimate partner violence screening services.
So the recommendations, the department and the DSPs must ensure that index testing is always voluntary and that people living with HIV truly understand this. The department and DSPs must screen to see if the individual's partners have ever been violent and record the answer to the question. No contacts who have been ever been violent or are at risk of being violent should be contacted. Adequate IPV services must be available at the facility or index testing should not take place. IP must monitor all adverse events through a proactive adverse events monitoring system with follow-up to assess violence, disclosure of people of HIV status, dissolution of the relationship, loss of housing, or loss of financial support. So now we are going for key populations.
Our next issue is centered around key populations. It is critical that key populations can access specific services to meet their specific needs. When we asked facility managers in our monitoring if they provide key population-specific services, in some places they say they do. However, when we follow up with questions around what these specific services are, it reveals that the services are not really on offer. So out of 43 facilities, only 12 said they provided services for transgender people, but for those services, this was even fewer. For example, only 2 out of 43 facilities offer trans outreach services, and only 1 out of 43 offer hormone therapy in the province. Or out of 43 facilities, only 10 said that they provided services for sex workers. In reality, 7 out of 43 offer lubricant, and only 2 out of 43 offer sex worker outreach services. Or out of 43 facilities, only 14 reported offering services specific for men who have sex with men. In reality, only 13 out of 43 offer PrEP to men having sex with men, and only 9 out of 43 offer MSM-friendly STI testing and treatment. 7 facilities said that they offer services for people who use drugs, but 0 actually offered any for people who use drugs, any of these services. So we're going to move on to some recorded community stories, and we also do have community members who are here to share their stories as well.
Ethanol asihlukumeza nje straight udoctor wakhona last month bengile zange anginake bese chayisa yebo bengigula lapho mangiya lapha udoctor bengu4 vele beyisikhathi sakhe chayisa mara kuba bengisele ngedwa akafunanga ngisiza ngamcela ukuthi ngicela ungisize because ngine 3 days angikhona ukuchama wathi yena wathi I'm off, you must come back tomorrow. Ngaphuma ngaye ekhemist ngasizakala ekhemist. Yahlukumezana kuba ngathi bayasicalula musa ukuthi thina singabantu abanjani abasifuni mhlambe sasa. Hayi ngicabanga ukuthi basijaja nje because mina nimazi la doctor ngiqala umbona. Umuntu osaziyo ngulo sisi osebenza reception. But udoctor yena akasazi nosazi mara wrong. Ngeke ngisaya ngizoya esibhedlela. Or ekhemist futhi.
Last 2020 bengiya clinic bengiphethwe ngama genital warts. Then ngafika lapha eclinic ke usister lona ngamtshela ngathi ngiyagula ngiphethwe isifo engasunderstand la ngaphansi wathi okay angikhumule ngalala le ya bed yabo nangilala lapho wathi ukhona umuntu osalala ngaphandle kwecondom kulesikhathi samanje nge2020 usalala ngaphandle kwecondom nisuka leswazini leniphethwe lesifo sendozigqwalisa la South Africa ne ngathi mina cha hayi ukuthi ngilala ngaphandle kwecondom maybe isifo lesidala sahlala ngikhani sivela manje ngisathi wathi asimncede umuntu ophethwe lokugula lokho hamba esibhedlela esikhulu bayokusiza khona ngathi mina esibhedlela esikhulu esikepe kona bangivumeni ngingangabi nena ngaseklini wathi hamba nje esibhedlela esikhulu ngesincede wangangibhalela incwadi wangangibhalela ini ngancena ke kuya esibhedlela esikhulu ngihamba ngaye pharmacy banginikeza omunye umuthi wokugcoba namaphilisi ngaphuza wona ke ngaba right ke ngeke ngikwazi ngiprefer vele ke pharmacy since vele mangisengibula vele ngepharmacy ngoba ngenyana lokuhlambalaza labona isilapha ya sometimes bakuvusiva umncane kakhulu yabo mabasaqala lokukuthuka nje no abahloniphi abakhulumi awangeke uma sex worker vela unavela umosi akekho umuntu ongakuhlonipha umosi vela ngeke abahloniphe abangabathi usex worker.
Sanmonani. Good morning, everyone. My name is Mandla Mahlangu. My name is Mandla Mahlangu. I take my treatment at Siat Clinic in Bethel at Mzinoni. Definitely we've got a problem. It's not mine, it's for everyone. But the stakeholders must know about it. We've got the attitude of the staff. Meaning from the security to the reception. There are times where the reception is not attended. Meaning you'll go there, you'll find there's no one in the reception. You'll start to wait there. By the time you'll get your file, you are already exhausted. Mind you, you might have pains, you might be sick and all that. Ungayenzeka uyagula or anything angeke uye clinic uma anuye nje unganalutho uzolinda ngaphandle elangeni. It's not a new thing because it's locked down now. Into ebeyiveli khona, it's getting worse now because it's locked down. Uzongena a consultation room. During your consultation, you'll get the professional there, whether it's a nurse or whatever, I don't know. But you'll find maybe there are 2 or 3. While you are busy consulting with her, then they are busy talking their stories with you there. That thing causes you as the patient to hide some of the information because of the privacy. I'm the member of the LGBTQ group. Yes, I'm gay, you can see. I find it difficult to discuss some issues concerning me with them as their healthcare professionals. Due to that, I feel that they need a huge training regarding our issues. Out of my understanding, when I look there, I feel like they've got a huge gap in terms of LGBTI group, because whenever you get in, they will see your face, you've got makeup and all that. First, they will give you the attitude regarding that. Secondly, they will ask you, why are you having makeup on your face? As if, wow, batho ba Modimo ke yenzakalani lana? So I feel like that. Then there are condoms and loops for LGBTIQ group. I haven't seen them in that particular clinic that I attend. And also the staff there, during my consultations, they never asked me anything regarding the condomization and all of that. So it shows me that they don't know anything about that. So to the stakeholders, my request is, I find it difficult if ever maybe the SANC, South African Nursing Council, it also must be included due to the fact that they need to answer because they are the ones that are giving the licenses to all these people, nurses and all healthcare practitioners. How do they give those people such whenever we as the patients are getting what we are getting? I see everyone is not happy regarding the attitude and the way they are doing their things. So definitely this must be attended. I thank you.
Sanibonani. Njengoba besechazile ubhuti ukuthi ikakhulu kakhulu kule clinic ayihambayo iSiyat. Ahlangabezana nako kakhulu impatho engalungile ayithola kubo nurse nabahlengikazi. Usho nokuthi kusukela ungena egateini uhlangabezana nama security uye nase reception uye nakuba abahlengikazi. It's worse ke mawufika ku reception ngezinye inkati uthola ukuthi awukho namuntu ozon attend ene wena ngalowo mzuzu uphathekile uqinekile ukugula unokugula kwakho. Njengoba sechazile ukuthi nimbona nje ukuthi yena ukhethe ukuphila yipi impilo uzikhethele impilo azikhethele yona. Kodwa kuba khona ke nokucwasana nokubuzana kuthenini kungani wena ugcobe lezi zinto ozigcobile kanti akamboni yini ukuthi yena uthanda ukuzenzela lento le. So uyakhathazeka kakhulu ngendlela abaphatha ngayo bona ngendlela abaphila ngayo. So uyachaza ukuthi ngokwazi kwakhe kulomkhakha wabo kukhona izinsiza ezitholakalayo abazikumele ukuthi bazisebenzise bona ngokwabo ukuzivikelela mhlambe mabaya emsemeni or benza ucansi. Now okufana njengama condom asetshenziswa yibona hayi lama condom eswajwayela ngithi banohlobo oluthize lwama condom. And then bese kuba khona futhi nezithambisi okuthiwa ama lubricant nawo angabe ucamba manga ngathi uke wakawabona akawaboni. So okumkhathaza kakhulu nini uyezwa nje iningi labantu bakhalaza bakhuluma zonke lezi zinto abazikhulumayo uyazibuza umbuzo ekuthenini ingabe abaphathi bona bathini ngalezimo abahlangabezana nazo. Ingabe lo mbutho lo obhekelele indlela abahlengikazi abaziphethe ngawo bizwa ngokuthiwa iSouth African Nursing Council yona ithini na mangabe izwa ukuthi izinto ezinje ziyenzakala. So uyacela ukuthi bangenelele nabo. So uyacela kuwo yonke imikhakha yabantu ababambisene nohulumeni nabezempilo ekuthenini akwenziwe okuthize ngako konke lokho ikakhulu ekufundiseni onesi ngendlela bona abaphila ngayo so that bazokwazi ukuthi basiphathe ngendlela efanele egculisayo njengawo wonke umuntu njengoba nabo baphila la eMzansi. Siyabonga.
Siyabonga. So the recommendations, the first one is that key populations, we all know that they live everywhere. They are part of our community, so we cannot separate them as it's them and us. We are one community. So the department and DSPs must provide key population specific service at general clinics, not only in drop-in centers, including training staff to provide key population friendly services and at least lubricants, outreach services, harm reduction services, including medically assisted treatment, hormone therapy, PrEP, STI testing, plus treatment, and information packages needs to be provided. The department should ensure that all clinic staff are sensitized on provision of key population-friendly services for sex workers, people who use drugs, men who have sex with men, and transgender people. And now we are going for tuberculosis.
Okay. The next slide, please. In 2019, 36,000 people living with HIV died of TB. TB remains the leading cause of death for people living with HIV in South Africa. One key area we monitor around TB is the level of TB infection control at our clinics. We ask 7 questions to assess TB infection control at facilities outlined on the graphic on the left. No clinics were awarded green status for checking all 6 best practice measures on the scorecard. Richitse scored 14 clinics yellow status. This translates to 33% of clinics being monitored, following about half of the best practice measures for infection control. It leaves 28 clinics, or just under 66% of clinics surveyed, failing altogether at meeting these 6 basic best practices to stop the spread of TB. We will now proceed to community stories relating to TB.
Sanibonani. Mina ngiyi-community member yase-Buffelsbaai. Ngi-survivor ye-TB. Before then, ngitholakala ukuthi ngibe ne-TB, bengisebenzisa iklinikhi yase-Buffelsbaai. Ngiyile kaningi eklinikhi, ngine-symptoms like ukuthi bengehla emtimbeni kuphela, but bengakhwehleli. Then if ngiya eklinikhi ngiyachaza ukuthi ngiyehla emtimbeni, then bangirana ama-test e-HIV na. Banginike isikotela ukuthi ngihambe ngimuke naso ngiphindze ngisilethe, but ma-results solo abuya athi negative. Then ngahlala isikhathi solo ngiyabuyelela ukuthi angikho right. Solo ma-results athi negative. Then shothi ngathatha isikhathi more than 3 months solo ngithola into leyi-1. Then ekhaya bangisa additional ngakhipha 500 rand. But okay kusho ukuthi nginetindaka ne, cause i-TB ngesintu basithi indaka. If usengiluze le mali leyo kule 500 rand, sengiyaqala lapho-ke ngiyakhwehlela, ngiyaqala ngiva ama-pain, ngiyabuyelela again eklinikhi. Solo ngiva ngiyagula, ngidocela ukuthi ningitaste. Bangitaste futhi, ma-results athi negative. Then ngaze ngagula ngaba worse. Ngiyabuyelela again futhi eklinikhi sengi-4 months. Then kwathi ngesikhathi ngacela ukuthi ngicela i-transfer ngiyobona dokotela esibhedlela. Bangifika kudokotela ngasho ukuthi ngidiva ngiso senginesikhathi and sengiyakhwehlela. Dokotela wangisa x-ray kwatholakala ukuthi ngine-TB. Then ngaqala i-treatment yami bekungu-1 December. Dokotela wangibuta ukuthi ngisebenzisa yiphi clinic ngasho ukuthi Buffelsbaai. Wangibhalela iletter ukuthi ngimixe eclinic. Eclinic banginika amaphilisi ami la ayingonatha 6 months. Ngawaqala amaphilisi but kungana change. Solo ngiyagula. Kanti banginike i-treatment le wrong sengine-MDR. Ngabona ukuthi solo ngiyagula kude mehluko sengi-6 months treatment. Ekhaya wathi hayi no, ngcono ushintshe iclinic. Ngacela i-transfer but i-transfer kwathatha isikhathi eclinic ukuthi banginike. Solo bangithethisa ukuthi ufuna i-transfer yani in. Then banginike i-transfer ngetala Emelo. Cause benginamamncane wami bekala Emelo. Ngasebenzisa i-town hall. Then wangifika e-town hall ngamikisa i-letter i-transfer. Wathi lo nurse says, "Stock nika amaphilisi cause sona 6 months ku treatment. Stock eda nga1 uthi 7 months but stock rana 8 uma test. Sithole ukuthi kwendakalani." Then bawarara lama test but ngilinze i-call. Ngalinza i-call ngisendlini. But sesi utholakale une-TB MDR. Uyathengakala e-clinic immediately. Uhlala khashana ngakanani stock linza. Ngafika mina la clinic. Then bangichazela ukuthi kumele ngihambe ngiye eSanta ngiyothola i-treatment lengqono kundlula lebe nginatha. Kanti sengimoshe isikhathi sami solo ngikule treatment leya. I-TB le solo ngiyithatha eBuffelsbaai Clinic. Then bangimove from la e-town hall bangisa eStanderton ngayothola i-treatment e-MDR. Ngathi ngisanatha i-treatment e-MDR ngaba nenkinga futhi ukuthi ekhaya sekushoniwe. Ngacela kudokotela sengina 1 month ngisesibhedlela. Ngicela ukuthi anginike cause beze ngijova every day. Ngicela umjovo ngiyakufuneral ngiyabuya. Wasidokotela kungasho ukuthi eBuffelsbaai. Wathi okay, kukhashana ngiyadischarge ngunika umjovo wakho uyumikisa eclinic. Ngahamba nemjovo ngomikisa eclinic la ngibuya khona. Bangijova umjovo waphela. Angacedi inyanga yami ekujova cause ujova 24 months. Okay, eclinic bathamba esibhedlela eShongwe Hospital yofuna umjovo. Ngaba nenkinga futhi. Bathi umjovo wena uwakuphi? Uchamuka kuphi? Uqale kuphi? Ngithi mina ngiqale eStanderton. Buyela khona emuva eStanderton cause umjovo wakho la awukho. Okay, bangizame wasihlola umunye sister. Okay, nekuthi ujike sidokuzamela iplan ukuthi ujove. But vele kufuna ubuyele back to la ubuya khona wathi asikwadi. Okay, ngahlala babajove bathi ungasala sebajova mina. Qale ngibamele bonke abajova. Ungasala abajova mina. Okay, after sengifikile tukwethi inyanga tekuthi imjovo sekufuna ngiqedze. Ngibe nenkinga futhi ye-discharge. Bathi angeke sikudischarge thina wena asikwadi. Sicela ubuyele back la ubuya khona. Ngithi mina anginamali. Bathi okay, sidokuphi transport leyo kubeka eStanderton. Bangiphe i-transport, okay, bangifonele. Ngithathe i-transport yongibeka eBarberton. Mangifika eBarberton bathi sesingebhadi. Awunayo i-transport leyo kubeka eStanderton. Uyalala la. Sidobona kusasa ukuthi uhamba ngani. Bangithathe bangifake ewadini ngilala. Ngithola transport the following day iye eStanderton. Mangifika eStanderton ngifune lo dokotela. Athi doctor why bangakadischarge kaShongwe? Ngithi mina bathi abangade. Athi lo dokotela no. Ku wrong lokho cause wena i-treatment uyicedzele ngala. Athathe ilifayile lami vele abhale cancel we-treatment. Then ngisuke eStanderton ngibuyele back to le Enkomazi. Mangifika eBarberton sesingebhadi awunayo i-taxi leyo kubeka ekhaya. Utolala ngilale futhi again lapha esibhedlela. Kuthi sengicedzile i-treatment ngiyolala lapha nebantu labane-MDR. Kuthi into ngena futhi onjani nami angitati. Ngilale lapha ewadini. The following day khani bangipha i-transport lengimukisako lengisa ekhaya. Manje ngaloko ke vele kwangivisa abhlungu kakhulu ngoba kungimanje angitati ukuthi i-TB itobuya noma njani cause basitshela ukuthi i-TB inekwenteka ibuye. Ngiyabonga.
Good day, everyone. I am a TB survivor. I actually was a patient at the Buffelsbaai Clinic for quite some time. And I've actually visited and consulted at the clinic on several occasions, but they could not detect what was actually bothering me. And I could actually note that I was actually losing weight. And after a while, because I have a relative here in Emelo, after going back and forth at Buffelsprite without any assistance, I then decided to visit my aunt who stays here in Emelo, who then actually ensured that I actually be admitted at Ermelo Town Clinic. And then at Ermelo Town Clinic, that's where I was actually assisted, and then I got to be admitted at the Santa Clinic. After a while, they discovered that I was actually now an MDR patient. And then I was initiated on treatment, and then I took treatment together with injections. And I sometime had a funeral at home, so I needed to go back home to attend the funeral. So I actually requested permission to go back home, and I was granted that permission. I went home, and at home, I was then sent to visit, is it Shongwe Hospital? At Shongwe Hospital, there were some concerns as to where I actually took my medication from, and I was then sent from pillar to post to actually go back to the facility where I started. And now at Shongwe, they then said that they must send me back to Santa again, Standerton. And now because of and then I was ferried from home, Buffelsprite, to up until Barberton. And then I could not proceed because of, I think it was distance or whatever trouble that they had. And from there on, I then proceeded straight again to Standerton. Continued with my medication, and then I went back to where I'm staying. But now my problem is that with this up and back, I think I'm a bit concerned as to say whether I might have contracted or might have reinfected myself with MDR. I don't know my status currently. Yeah. Thank you.
Sanibonani. Mina ngi-community member yase-Buffelsprite. Ndokhuluma story se-cousin yami le that she passed away last year. I-cousin yami ine-TB. Inokuya e-clinic e-Buffelsprite Clinic. Na inokuya e-Buffelsprite Clinic kani udla i-treatment i-HIV. Beyasa-develop ama-glands la at the back. So naka e-Buffelsprite Clinic beyangakhwehleli. Nafika batshela ukuthi mina angikho right. And la sengidevelop ama-glands bambuta ukuthi uyakhwehlela yini. Athena no akakhwehleli. Bathi since ungakhwehleli angeke size sisho ukuthi i-TB because thina i-TB siyidiagnose nge-sputum. Funa sithole sona kuze sithole ukuthi vele wena une-TB. So then kwahamba isikhathi wagula kakhulu. Nakagula kakhulu cousin wahamba vele esibhedlela. Nafika esibhedlela kanti vele sowugule kakhulu isikhathi. Nafika le bamenda ama-test, nabamenda ama-test bathola ukuthi une-TB and vele bekasa weak. Nabathola ukuthi une-TB wasinakacala i-treatment, vele i-treatment yavele yamcinzetela vele wavele washona. And vele beka weak, akakabulawe HIV. I-treatment yakhe i-HIV bekayidla kahle. But ubulawe i-TB. Yabong.
Good day, everyone. I am here to relate a story of my cousin who was also suffering of TB and also living with HIV. I mean, she had developed some swollen glands, and she has actually suffered a lot and actually gotten weak to a stage that I think when they actually ran some tests, they could not assist her because they said that they could only diagnose TB through sputum. and now they could not actually use the Solent glands as a reference for TB treatment. And this has actually affected my cousin such that it became unbearable for her, and she suddenly passed on. Yeah, thank you.
Sanibonani, igama lami nguNyanga wakangwenya. Ngiqhamuka eMbalenhle, Pauline Moripe Clinic, Morupeng. This is a serious problem, really serious problem. Because we experienced in 2013, ngahamba ngayocircumcise, ngathola ukuthi ngi-HIV positive. So I stay for 3 to 4 days ekhaya, banginikeza incwadi ukuthi ngiyimixe clinic. So I stayed 3 to 4 days ekhaya. After that, because I was in pain, so I go to the clinic. Ngafika ngathola umunye sister lapha, but akasekho manje. Wangitshela ukuthi hayi ngihlele nale ncwadi all along. Ngamtshela ukuthi bengisase kunama pain yabo. So angikwazi ukuthi ngize la. Wangitshela ukuthi all right, go to save your pain ke sizobuye sikuncede. Lucky ngisakhuluma lo ngidiscussa nami kusho ukuthi enhlek mina ke ngumuntu vele onenkani. Sometimes angithanda ukuthi umuntu adlale ngami. So ngisathathana naye vele kanjalo ukuthi ngazongitshela uDoti wena. Ngene umunye sister asibuza ukuthi kwenza kanjani, ngomtshela ukuthi alo yangihlanyela lo. Ngoba ngitshela ukuthi so ngiyamtshela ukuthi nayi incwadi banginikeze, so I was in pain. Angeke ngize eclinic ngikuma pain. So I need ukuthi ngihlale kancane bese ngiyazake. So yena ngitshela ukuthi ngibuyele back ngesave ama pain ami bese ngiyabuya. What's that? So ngiyacabanga abakhuluma boyithu ngoba wambiza baphuma naye. Ngicabanga ukuthi wamtshela ukuthi no wrong, because azange sasizwa uye ngasizwa umunye. Uye lo. So I started this thing on 2014, yama ARV. The same problem abantu abakhuluma ngayo, attitude yasibhedlela yaseclinic, long queue. And alright ngakubekezelela lokho because bengina experience bekhona uantu hambe kayenza iclinic. Ngafisi ukuthi ngigule ngelinye ilanga, yazi ngakufisi lokho. Ukuthi ngazi ngathi ngahlala ngagula okanye noma ngathi ngiyagula vele ngife. Not to go there eclinic ngiyoma lapha eclinic the whole day ngibukela abantu abangawuthanda umsebenzi wabo. Because now uyabheka lapha yana labantu laba benza umsebenzi kwangathi abawuthanda umsebenzi wabo, because indlela abawenza ngayo ngathi abasi professional like the way. So iyama experience akhona la even till today sasabhekana nalezo inkinga lezo. Ufika uvuka ekseni ngo5 uyahamba ngo4. Namanje kusasenjani noma ngathi uyafona manje uzakuthetha umunye ngifike ngo5 ngisasekhona manje. So izinto zonke lezo esibhekana nazo, when you go inside uzothola ama nurse ane attitude yawo ifile. So kunalo sister Bonga uya ke umuntu engacabana naye mina ngoba yena ke unale style lesi sokuthi wela zange ngibe nebhadi lakhe, bengibabona nje abanye ba complain, hey awuphethanga oliphethanga i-empty kotkoti amaphilisi angithi ayasala. So oliphethanga kotkoti unomsa ngeke azakunika. Hey, and mina vele bengajwayela ngwaphatha. Ngisitshela nje ukuthi hayi ngizobona khona. Lucky ngibe nenhlanhla ngingangeni kuye ngoba lapha yana kuneminyango u3. So lama file nabawa distributor in 3 doors. So ngifisa ukuthi ifile lami lingangeni eroomini laNoms. Lucky vele lingangeni in 2018 lalingena wambuza ukuthi icontainer ivele mina ngijwayelanga ukuyiphatha. Ngambuza ukuthi for in ngiphathele for in icontainer. Wathi ngifuna ukubona ukuthi amaphilisi akasela ngaka, ngamtshela ngathi kusele 3. Wathi angeke ngizwe ngawe mina in landi ubuyele landi container emuva. Ngamtshela ukuthi indaba ngichamuke ekudeni mina. Angeke ngibuyele emuva ngiyolanda icontainer. Wathi ngiyakutshela ngeke ngikusize la. Wababiza omunye next. Ngabona ngoba vele ngiyoba ngisengishila ngathi nginenhliziyo encane mina. Usisi uyasho usisi wami lona ke sihlala naye ngasithatha same treatment same clinic. Singabantu abanenkani vele ngagcina ngibona ukuthi ngizomshaya ngcono ngiphume ngizambela ngiyashesha ukushaya futhi umuntu nakangijwayela so ngaphuma ngazambela ngiyolanda leyo container nganginhliziyo yami ayithi ngiyoyilanda nangifika ekhaya angayihlalela because I need to go back to 4 plus minus kilometers ngiyolanda le container ngibuye and ngize kuseni la ngifike ngo5 ngo1 still ngale nkathi so 1 to 2 uzongitshela ukuthi angijike ngiback ngibuye lana le container so yangiphatha kabi leyo nto leyo because azange ngibuyele ngayihlalela ngahamba ngakusasa ngayibukela wathi ngakusasa bangibuza ngathola umunye sister wathi because athi file lakho likuphi ngadali beku sister Noms wahamba umbuzo wathi ubleyo umuntu akeze la ngaya kuye wathi ngoba ngithewela ndi container izolo waye ungabuya ngamtshela ngathi hayi ekhaya kusekudina ngithi ngotshelile so bese ngidiniwe mina wathi uzenzela umathanda la ini ngaphe vele athi manje nami yabona vele njengoba ngishila ngathi mina nginanhliziyo ke ngamtshela ngadalela la gogo uma ngabe sokhathela ukusebenza ungitshele ngiza kuphumuza mina ya mangitshela udodi la nginikeza amaphilisi ami ngihambe vele ke hey kwaba leyo issue ke leyo ke vele kwangitshela ukuthi usadla ngamthola adla vele wathi usadla yena ngiphumelela ngaphandle uzanginceda nangiceda ubeka amabrele la ukubuka show ngamtshela ngathi ngizowakhuphula la mabrele ngamtshela mara nasengiphuma eminyanga ngamtshela ngathi wena gogo ngizowakhuphula la mabrele ngelinye ilanga alright ningahlala bafethu kodwa le nto yangiphatha kabi ngoba ngathi nangibuyele emuva ngadefaulter amaphilisi ami for 3 months ngayeka vele ngathi yazi ngizoshaya umuntu ngoba vele cishe inhliziyo anginayo ngiyamthanda umuntu ongihloniphayo ngoba nami ngiyamhlonipha umuntu so umuntu akazongijwayela vele ngisheshe ngishaye masinyane ngabona ukuthi ngizocabana naye ngcono ngiyiyeke le doti le ngayiyeka vele so uNkulunkulu ke ipartner yami umuntu nayo nenqondo sabonisana wangibonisa ukuthi no man ungayiyeki impilo yakho iqova umunye umuntu ngendaba yokuthi kanjani wena go back to thatha ama treatment wakho and then uNomsa umyeke netso ungabe nendaba noNomsa ngeke akwenzele next hayi savumelana ke and then I go back ke ngathi nangibuyela ngathola umunye sister wangitshela ukuthi why amaphilisi bese ngasawalandi because uyabona ngine gap eningi ngamchazela istory sami naye because so ni staff even self staff nasiboma nangathi uyasibuza naso sibe bo anonymous wayena uNomsa bayamfaka ngoba ngathi nangumtshela ukuthi uNomsa wenze so what azange asikhulume next nokuthi njani ngithethisa wanginceda wathi wavele wathi wanginceda so that is a very serious problem bafethu so my concern is that ngicale last month bengiyovuselela ifile lami was going again kuyiNomsa but I was surprised because azange ngibuza ukuthi iphi container vele bengingayiphethanga yeah because sekangazi azange ngibuza ukuthi container ubavele wathi ngibuka phansi njengoba ngisho phansi amabrele wathi ngahlala la celeni kwakhe ngambuka nje ngagada ukuthi azongibuza futhi ukuthi iphi container azange azangibuza wayenza everything wanginikeza one so it's when I saw a treatment action campaign that day because ngalasikhathi bakhona lapha yana everything was normal ikahle man everything was moving all right nami ngaba surprised ukuthi kwenze njani namhlanje so kunentombazana yakhona lapha le treatment campaign ngayibuza ngathi nina nhleke njengoba nikipe ibovu nenzani la bathi hayi sithatha ama complaint wenu njengama patient kanjani ngathi hayi lento yenu ukudlala lokho because lento lezi bafethu ama organization alwela abantu asiwathathi serious thina because sibona ngathi ukudlala vele lento yenu ifana ne service delivery yebo abantu be service delivery each and every year they come and promise you but they don't deliver so engikucelayo ke njengama organization lawo enibhekele ama saving lives wabantu nayo ibhuti loyana ushilo wathi kulama agenda wabo lapha yana baningi abantu balokhunjana abalokhunjana nakhona lekithi sifesane nayo lento embalenhle so nina njengama campaign okanye ama organization enikhona mina bengifisa noma owami umbono ukuthi mhlambe ni deploy abantu lapho nibafaka abantu lapho ukuthi inangabi problem ikhona immediately azi umuntu ukuthi immediately nangine problem you report lapho because now we are in a problem at clinic we don't know where you going bakutshela ukuthi bhali complaint ifake lapha eboxini ntambama bayayivula le bhokisi bakhethe ezinhle zodwa ezimbi basishisa basifaka emlilweni. So kuba ngcono nangabe mina ngibona ngendlela ekuzoba ngcono ngayo ukuthi nina ni deploy abantu babe khona emaklinikhi nasesibhedlela. If ever ungakhuluma ngesibhedlela sethu futhi i-Venda Hospital ngaba inkinga kakhulu ngashona ilanga ngakhuluma ngayo. So ngiyacela kakhulu njengani masingabuyi la after 2 years noma after 3 years sizokhuluma nga same problem yama waiting period yama waiting list amaningi. Sikhulume futhi ngokuthi treatment ayisi right. Sikhulume ngento esikhulume ngayo ngo-2021. Please guys, let's fight for this. Mina ngiyanisupport abafethu nangabe nizokubona impilo zabantu zide ngoba phela vele lapha emaklinikhi nawuthi abheka akekho umuntu oconcern nje ukuthi alwele impilo zabantu. Abantu nangu sisi bekakhala manje athi yena ucabanga uyiyeka zonke lezi zinto. It's because noma ngabe ahlangabezana neproblem immediately nawuhlangabezana neproblem kwase kube khona immediately umuntu oyisolvayo. Ngazi ukuthi ngiyongena lapha oh yangichoshela wena uNomsa. Alright ngimshiye kanjalo ngiphume ngiyongena lapha. Ebhuti noma sisi nangu uNomsa uthi lapha kimi. Asukume sisinomsa la sinenkinga lo umuntu uthini kuye. So isolve it immediately. Ngiyacabanga ukuthi kuzoba right kanjalo. Matpushani kakhulu njengama NGO. Siyabonga umsebenzi wenu muhle. Thank you.
Good day, everyone. I started to consult for a circumcision around 2013, and I was also diagnosed with HIV. I then actually I am using polinamurapate. I had on occasion heard that there's a nurse known as Unomsa Bongwe, who's actually always ill-treating patient. So, I mean, we're experiencing staff attitude in that facility. It's very dire situation. Around 2014, I then I was initiated on art and started taking my treatment. But it has been my wish all along not to actually consult with NOMSA. Because when you visit the facility, they'll always pair you amongst the 3 doors. So it was my wish not to dare go in that Nakujana, because I know myself that I'm a very short-tempered person and I wouldn't take kindly to her taunting. But unfortunately, it had happened that one day I was actually meant to consult with her. I have heard that when you consult with her, you must always bring along your ARV containers. Without the ARV containers, you would not be assisted. So she actually also asked me as to say where my container was, and on that day, I did not bring it along. So I was actually angry at her, and I told her that I know as to how many pills I had left. I had 3 on that day, and she actually refused to actually offer me a service on that day, and then I had to go back home. I did not come back because I'm staying far from that facility. So on the next day, I then went back to the facility, and I was then assisted by another nursing sister in that facility, who then asked me as to say, why was I not, why did I not return? Because you could see that I consulted yesterday. I then actually informed the nurse that I had a nasty encounter with nursing sister Nomsa, and then she also, I could see that she knows of her tendencies, and she could also affirm what we all experiencing. So I know and trust that if we could actually, even the nursing staff, we could actually ask them or interview them anonymously, they would actually tell you to say that this NOMSA is actually ill-treating patients. And for quite some time, and at one stage, at one stage, after 2018, I think, if I'm not mistaken, I decided to actually stop taking treatment for a while. And my partner actually sat me down and convinced me to actually not to, take too much NOMSA's taunting and then go back and take my treatment. I decided to go back and actually continue with my treatment. I think that is when I saw or came across TAC members in the facility who were actually visiting the facility. You could see that they were busy there, and then I inquired as to what is it that they were doing there. Then they explained to me that they're actually there to monitor the facility, to look at the complaints of patients. And I felt encouraged to say, I'm still also convinced that if we could actually do this more, even place some of our members in that facility, I think things could go better. This thing of waiting too long, it doesn't help. Also, you could actually listen from the other testimony of other people or other people with other genders that they're also facing that. I mean, that Paulina Mrapedi is very troublesome, I can say. So I wish that you could actually reach far to actually assist the communities. Thank you.
We are going for recommendations. By the end of August, the Department of Health should carry out a full audit of all public health facilities in the province to assess whether sufficient TB infection control measures are in place. They need to send a circular to all facilities to ensure that all windows are kept open, TB infection control posters to be displayed in the visible places in the waiting area, patients to be screened for TB symptoms upon arrival, integrate with COVID-19 screening. People coughing or with TB symptoms to be seen first to reduce the risk of transmission. People who are coughing to be separated from those who are not while waiting. Where infrastructure issues mean that public facility create a TB risk factor, each is too small or poor ventilation, an urgent, fully funded turnaround strategy must be developed to outline how these challenges will be rectified. So now we are going for clinic committees.
Okay, thank you, Chair. We now move on to clinic committees. Clinic committees are meant to ensure community participation at a local and district level. They are key to ensuring accountability and a successful AIDS and TB response. Yet, of the 43 sites monitored by Richidze, only 16 have a functional clinic committee. Too many still lack a clear understanding of their role and their responsibility. I'm going to hand over to our district organizer, Lucky Gwebu, who will tell us the impact this has on the work on Richidze, where we go into facilities with non-functioning clinic committees.
Thank you. You'll pardon me for not introducing myself earlier on. I think I was hijacked by leadership of Belinda, and I felt that introducing myself would have actually taken longer. I blame the table up front as well. Good afternoon. My name is Lucky Gwebu. I'm the current Khartsibande and Nkangala district organizer. We are actually are responsible for conducting the community-led monitoring on all the Sienza site in Khartsibande, Nkangala, and as well as Ehlanzeni. As Undivuo explained that I think there are 43 facilities, those that we are monitoring in Mpumalanga, right? And out of the 43 facilities, only 16 facilities have clinic committees. Now, having a clinic committee if it is not functional, it is just as well as it's non-existent, right? What is a functional clinic committee? A functional clinic committee, it's a committee that meets on a monthly or bi-monthly basis, and they make sure that they actually listen to clients' complaints and try to address those complaints, right? And also give an opportunity for outside patients to actually make a contribution in the running of the clinic. I mean, with such complaints and testimonies that those that we've listened here, we should not be actually be at this level if we had functional clinic committees. Now, in our experience, what we've actually encountered in the most facilities where these clinic committees are at, you would find that the clinic committee members, they are not actually well supported. And worst of all, they do not even understand their responsibilities. I was amazed or shocked, yeah, to be exact. I was shocked at seeing the attitude and tendency of the clinic committee members. I mean, they were behaving like clinic staff, which it should not be the case, right? They should be assisting, they should be standing in between the clinic facility and also representing the interests of the community, right? But you'd find that, I mean, in the two facilities, those that I'm actually servicing here in Egersibande and Nkangala at Empumelelweni, and there's one also, Polinam Rapedi. Polinam Rapedi, the gentleman there, I think he is passionate, but his passion is misguided because I think he behaves as if he is the facility manager, though he's actually the treasurer, or he's supposed to be the treasurer or something else. They have a chairperson who's actually a ward committee, right? And then also at Empumelelweni, which is at Nkangala, also the person who's responsible, he's the sole person who actually attends. When you visit the facility, he'll actually be present. But I think interacting with a client, and then when you engage with him, because I think the study actually offers us an opportunity to give feedback to a facility manager. When you interact with the facility manager to give the report, he will actually be defending the facility to say, but what is happening here? Whether does he understand the role or not? I think we need to ensure that I think these people are actually empowered or capacitated enough to understand their roles and responsibilities. We should not be having such situations that you have people complaining, reporting to us as this opportunity arises to say that they're encountering problem when there is a functional clinic committee. And in most cases, I mean, out of the 43, when you inquire from the OPM to say, do you have a clinic committee in this facility, they will tell you that it is very difficult to get hold of the chairperson. The chairperson is the ward and training council, that should actually sit in as a chairperson and also assisting the clinic manager. But you know that, I mean, they hardly talk. And even the nursing sister do not have phones to actually get hold of this. I think, it's so many things. I mean, department must actually make sure that they actually inject resources to making sure that these committees are actually becoming viable and are actually a vehicle to actually assisting in addressing some of the challenges that we've actually witnessed here today. Thank you.
Thank you. Now we are going for recommendations. The Mpumalanga, oh, sorry. Okay. The Mpumalanga Department of Health should provide an audit report of the functionality of clinic committees by the end of August 2021. By the end of June 2021, a circular should be issued to all healthcare facilities in the province ordering the establishment of clinic committees as required in the law, and providing ongoing guidance to facilities and on the correct and lawful operations of these critical important structures. Furthermore, these structures must have proper community presentation. All clinic committees should be capacitated on their roles and responsibilities by the end of August 2021. And an annual review should take place of functionality of each structure by the Mpumalanga Department of Health. So this is the end of our presentation. However, this is not the end of our program. As I've indicated earlier on, is that we are working with partner organizations, which are organization of people living with HIV. Now I will give only 3 minutes to each partner organization. I understand that we have NAPWA, a person who is Nompumelelo Mbuyisa, and then she'll be followed by Rev Mvula Kamnisi from Sanarela, and the last person will be Simon Shongwe from Treatment Action Campaign, in that particular order. And after that, we will ask in Mpumalanga Department of Health to respond to other issues that were raised by communities here. After, we will have the National Department of Health. So, for partner organization in that particular order, Nompumelelo.
Unompumelelo Mbuyisa ukhulumayo ngiqhamuka kwaNAPWA. Ngiyalibonga leli thuba. Manje uNAPWA wenza i-human rights violation emakliniki. Izinto enizikhulume la, izinto esihlangabezana nazo emakliniki. Ene thina njengama-activists emakliniki basivalela ngaphandle. Abafuni ukuthi sazi ukuthi emakliniki kwenzakalani, niphatheka kanjani. Kodwa ke sicela ukusebenzisana ukuthi siyilwe le mpilo. Ngiyabonga.
Mbuyisa. She's representing NAPWA today, and she confirms to us that she's also working with the department in conducting human rights violations in the facilities. She also alleges that because of them being activists on the ground, they are actually not allowed to gain access or to freely interact to actually unearth some of these frustration or violations. And she pleads with the department and all stakeholders to actually work together so that they could actually arrive at a point of convergence. Oh, yeah. Thank you.
Ngiyanibingelela, to be brief, I'm Rev Mvula Kamnisi, the provincial leader, yes, Sanarela in the province, but then I'm having a district leader, Sanarela la, Echetsbane district, Umfundisi, Uvilani, Baba, Abagbone, Nzokobega. Yeah, as Sanarela, our emphasis is on the multi-sectoral approach that is needed. Is currently happening to address the issues and concerns being raised, you know, especially for the Department of Health to take responsibility of the institutional stigma experience in health care facilities in order to realize the 1990 NSP goal objectives and also the NTP goal for a free HIV/AIDS generation in 2030. Secondly, the reintroduction and the funding of adherence clubs, you know, I think that it is key. Also, the bringing to books or charging of those officials involved in human rights violation at facility level in terms of a Bill of Rights and also the President's Charter, and also the establishment and the proper functionality and properly independent clinic committees that need to be established. Lastly, also the local AIDS council, DAC, and impact responses and reports on the establishment of sectors to address issue concern of key POPs. As Sanarela, we hereby submit in Ngiyabonga.
Sanibonani, igama lami ngubaba Mvula. Ngihamba lana nomphathiswa waku district ubaba uVilade nathi sihleli la ngaphambili si representa yona isanarela nayo isebenza ne department isebenze nawo amanye ama partner wonke ukuthi babambisane ukuthi kusetshenziswane kuzokwazi ukuthi kulisane nawo lama violations. Kusemqoka ke kithina njengesanarela ukuthi i-department ayibonelele ekuthenini iyasupporta ama adherence clubs futhi yenze sure ukuthi i-department mayenza njalo izokwenza sure ukuthi lo mhlahlandlela eyawuzibekela wona ye-1990 strategy uyakhona ukuphumelela. And then futhi iyabona ukuthi Sanarela iyawuxhasa umzabalazo wabantu abaphila nobulili obufanayo ekuthenini iyadinga ukuthi nabo basekelwe basupporte njengawo wonke umuntu ukuze bonke bahambe ngomgaqo siseko wala South Africa. Siyabonga.
Sanibonani. Igama lami nginguSimon Wakashonga serving ku PwC ka treatment action campaign. The challenges raised today are so truthful and so touching. The issue yama staff attitude and all that because it leads ekuthenini abantu bagcine ba defaulter and banga adhere. I'm so happy the issue raised issue ye counseling. We also questioning the department day in and day out as to when is the counseling be enough, gumuntu, and the post and the pre-counseling. And also good issue le comrade Lucky I raisile yogu establishwa kwama clinic committee. Ukuthi abonakala angekho oriented ngokomsebenzi wabo. And another issue la engavelanga the issue of interference yama security guards nabo groundsmen because gcina sekuyibo abaphethe ema clinic. But office ke sine plan lokuthi train ama district committee comrades sooner nje that will be addressed, which also will address le ndaba ye staff attitude because sine inkinga ye internal stigma. So by capacitating the clinic committee, and I think all that will be addressed. And I'd like to also thank the sisters organization ukuthi working together we can achieve the community can get the quality comprehensive healthcare service that is dignified, affordable and accessible. I thank you.
Simon Shongwe nami ngihlala kusigungu lana se PwC kwa TAC nathi sikuwo lo mzabalazo wokuthi silwisane sikhulumele amalungelo wabantu abaphila ne-HIV kanye ne-TB. Kuyangimangaza kakhulu kuzo zonke lezi zinto ebesezikhuluma la kuziliqiniso zonke zibhlungu mawuzimamele uzizwa. So umbuzo wethu ukuthi tina sithi i-counseling ebhedlela nasemakliniki ngabe istojoleni or kungani i-counseling isuka lana iphela la kanti i-counseling kumele ukuthi kube khona i-pre and post counseling so that abantu bazokwazi ukuthi bazibophezele kahle ku-treatment. Ngisizwile lana uLucky mayekhuluma athi ma-clinic committee awasebenzi kahle. Nathi sisemkhankasweni ukuthi sincedise ne-department ukuthi sibatraine bonke lama clinic committee ukwenzela ukuthi benze umsebenzi ngendlela ekahle. And then ngibonge futhi nabalingani bethu bama partner organization lawa khona la ngaphakathi ukuthi siqhubeke sibambisane indlela iyaphambili. Siyabonga.
Thank you very much. Now we are going to have a response from the Department of Health. I understand that we have Mr. Duminkosi in our midst. He's from the Department of Health, the provincial office. And also in our midst, we have a Deputy PHC Manager, Oscar, so you are recognized. But we will allow Ukomre Unkosi to respond. I nearly said comrade, sorry.
Kuzaba inking ngoba uyaresponda ey'nkingeni eziningi kakhulu. So siyathemba nje ukuthi simnikeze ithuba enze lo ama commitment wakhe mhlambe ke singayi interpret or si translate for abazidingayo le nakho nje commitment. Akahambi yedwana ubaba uNkosi, uhamba no mphathi we district kungukuthi mhlambe lokho kwenziwe district phela ngithi ku-edda kubaba uNkosi umsebenzi wababa uNkosi in the province. Ibaba uNkosi angisakwazi ma. Ngiyabonga.
Ngiyazakala. Yes. Ngibonge to be invited into this sitting. I really appreciate it on a personal basis. Just personally for me, I think it has been very much enriching to be part of this sitting today. You know, for once you have an opportunity to hear for yourself from the beneficiaries of the service that you are actually offering. I think it's a very rare opportunity for some of us who are based at province, but who are not either in a clinic or in a hospital where the actual experiences that you guys have been sharing we're able to see. Maybe before I start and I respond further on some of the things, maybe let me start by apologizing on behalf of the acting Deputy Director General, Ms. Makwetla, and also the head of department, the acting head of department, Ms. Tutumdluli, who actually delegated me to come here. They would have loved to be part of this sitting today, but unfortunately today they are due to have with a meeting with the portfolio committee in the legislature. So they could not therefore be with us. And let me also indicate that we also have other senior managers in the department, the director for TB, Director M&E on HIV, which is Ms. Tutumbambo, as also Dr. Mona, who is the director for M&E on HIV, who are also currently connected in this sitting. So actually they are virtually listening and experiencing also what is actually going through. Really, we really appreciate that. And I'm also happy that I managed to come to be here physically. And I think those who either are joining virtually, I think they are, in as much as they are able to share, to get a sense of what's happening, I think they are missing on the emotional aspect of what is happening here and what is being shared here. Because, you know, seeing a voice of a person from the other side is different than when you even see the person himself or herself. So I'm really enriched with the experience of being here today. Maybe to say to the community and everyone here that the HOD has actually requested that if the recommendations can be shared with the head of department, and then the department may be able to respond in detail on all of the issues that you have raised in 2 weeks' time, the department will be able to respond in writing on some of the issues that have been raised here. And I think that's what the head of department has actually advised, that it happens. And I would also appreciate that if we can really, in as much as we have the document, I would appreciate if the organization can share the recorded stories. It could be either in a form of a disc or in a form of anything, but if it can be part of a package that you can share with the department, so that even the department can use that in whatever platforms of meeting, just even for those who provide the service, to can have a sense of how you feel as beneficiaries of the service. I think for me, it will really go a long way in assisting in addressing some of the issues that you have actually raised. I do acknowledge, however, quite a lot, if not most of what is being raised here, especially also on what is in this report. But I will really be specific on some of the things that you have raised, that I know that the department indeed is working on it, and which I would recommend to the organization here, that also it would have been better to reflect on some of the facilities where you find some form of excellence vis-a-vis what you get on another facility. Because that, at least, it helps to say, if the department has a potential to can have something good in this facility, why can't you have the same in another facility? So I would appreciate that, even if in future you can even actually also have a picture of where you're getting good lessons, because I can safely say now that there are facilities which I know on issues of filing, for an example. I know personally that filing system is one of the challenges that we have in our department in the facilities. But I can still say, without any fear of contradiction, that there are facilities where you find the best filing system and the most effective and functional filing system. And I'm definitely sure that the team that has been working on this, they might have actually come across such facilities. And I would love that we also capture such experiences that we actually come across. Furthermore, I would also wish to indicate that indeed COVID-19 has actually affected the department severely in terms of our services. It did not only affect us in terms of how we provide the service, but I think it has also affected the beneficiaries of our services in terms of how they access the service. So it has really been a very challenging but a learning experience in terms of how best can we offer some of the services in future. Because I think something good came out of COVID-19 in terms of what other things we can actually do better. And of course, as I was listening, what comes out very loud is the issue of attitude by our service providers, which are the clinicians in the facilities. I think that is coming out very loud. And it was interesting for me that this one year of this, just a day after, like yesterday, the department has actually, through the head of department, have set up a team of clinicians that will be looking at issues of medical negligence. Specifically, it's that committee that was set up yesterday is basically will be looking at these issues that you guys are, you've been raising today. The issues, among other issues that the committee is actually will be looking at, is the issues of patient confidentiality. They have been actually tasked to say, let us look at how do we actually maintain that confidentiality, because by act, in terms of the Constitution, in terms of the National Health Act, in terms of the Consumer Act, and many other acts that regulates our provision of service, we are actually expected to ensure confidentiality of our clients. And among other issues that they will be looking at, the issue of informed consent. The National Health Act, the Children's Act requires, even the Constitution requires that there be informed consent. And informed consent means you need to inform a patient of each and every step of the way as you give him or her a service. If you are going to actually conduct any test, you need to explain the test that you are going to, that the person you conduct, why are you conducting the test, how good will that be, how is it going to help that particular patient, and you need to consent on it to say you agree. Even on a treatment that you are going to be given, you have to consent to that treatment. You have to be told how the treatment works, what are the side effects of the treatment, and how the side effects are dealt with. And you have a right to choose not to take that treatment. So those are issues that this committee will actually be looking at, and also issues of right to, and access to health care. The National Health Act, it says you have a right to health care. And if, therefore, in terms of the Act, you have a right to health care, how then do we make it as service providers that that right is realized? So that you don't feel, as you come to our facilities, when we offer that service, as if we are doing you a favor. Because that is the Act. The Act requires us to actually provide you with that service. It's not a favor. So under no circumstances we should be actually treating our clients as if that is they are being done a favor. Among other things that that committee will be looking at is to say, how do we retain the dignity of our clients? Because we have a responsibility in terms of the Act that we don't take away your dignity. Whilst we provide you a service, we have to provide you that service with dignity. And you have to come out of that facility or of that consulting room feeling that indeed you have been treated with dignity. So those are some of the things that they will be looking at. And lastly, the issues of doing a skills audit and skilling our clinicians. Because some of our clinicians, either nurses or doctors, they may behave in a particular way, not only because they are just behaving that way, but because they lack the necessary skills. So identify those skills so that we are able to actually train our clinicians on those particular skills that they need. So those are things that, Chair, that I thought I need to respond to generally so. And I will, however, then go further and respond to some of the specific issues because as I'm sitting here, I'm the senior manager for HIV and AIDS in this province, which therefore I'm responsible for the HIV services that you are getting in our facilities. And I wish to say, Chairperson, that I've been running, I had an opportunity to start with the HIV treatment in this province since 2004. And we started with this service at a time where our sisters, our brothers, our mothers were dying in the absence of treatment. And one was given that responsibility to make sure that treatment is available. One was given a responsibility to make sure that we offer an HIV treatment service that saves lives. Personally, I'm happy that come 2021, in the province of Mpumalanga alone, we already have about 500,000 people that are getting treatment in this province. For me, this is not 500,000 people that are getting treatment. For me, it's lives saved. For me, is that child who has an opportunity to grow with his mother or father. For me, is that opportunity for that mother or that father to see his or her children growing up and becoming something. So I wish to say that, yes, the service might not be the best of what it could be, but for some of us in health, we run the service with a principle that says, do no harm. So it's very disheartening when you hear that there is a person who came for a health service but came out feeling sad, feeling hurt, because it is a direct opposite of what is expected of us as service providers. So I'm just going to respond just in short on those aspects that actually speaks to HIV in particular, because it is my specific area of responsibility, and maybe I can be able to respond directly. And I will start with the art continuity. And I'm raising this because, and also I'm noting the recommendations that you guys have actually made. And I think those are part of the recommendations that I think fall directly within my scope of responsibility in terms of running with them. And I note first the issue of clients, some clients not being given 2 months or 3 months stock, and we have clients that are receiving 1 month stock instead of 2 months, or instead of 3 months, or 6 months, or so forth. And really take this opportunity to indicate that, as you can see, the numbers of those clients that getting treatment, 1 month stock treatment, ideally, it has to be those clients who are on treatment for a period less than 6 months. It has to be those clients with a treatment less than 6 months. The reason why, it's because when you start treatment today, we can't give you 2 months, because you are still going to go through some experiences. You're still going to have some side effect. So we will have to actually come back to the facility so that we can monitor you and begin to see and be confident that the treatment is working, and we assist you in dealing with whatever side effects there are. So hence, we're giving you a 1 month stock so that you can come in the next month until you are probably 6 months. At 6 months, that's when we take a viral load. You might have noticed, Chair, that we are saying those clients who are virally suppressed, they are about 82. Actually, they are supposed to be 90%. But we are saying at 6 months you should be virally suppressed. And once you are virally suppressed, then we are sure that the treatment is working and you are responding well to treatment. And then thereafter, you can then be eligible. In other words, we can then give you either a 2-month stock or a 3-month stock. Because now we are sure that you don't have any side effects from the treatment, and we are sure that the treatment is working for you, and then you can be given 2 or 3 months stock. So basically, that's how it actually works. I thought I need to actually clarify that so that people understand it. But then it happens again. At 6 months when you are not virally suppressed, that's when we will then continue to give you a 1-month stock. Because we have to actually eventually be able to establish why are you not suppressing. Because with the treatment that we are giving now, at 6 months you should be virally suppressed. So that is the reason why we would not actually give you that treatment. But nonetheless, the basic principle is that we give clients a minimum of 2-month stock and a maximum of 3. Of 3 stocks, of 3 months. And the reason why, maybe to emphasize that, is that it's not only about us giving you 2 or 3 months. There are a number of factors. One, the factor is that it depends on the stock that is available. Remember, ARVs we're buying from suppliers. So suppliers might not have the sufficient quantities we need. And the fewer the quantities, the less we give each one of you. Because you find that even if we want to give each one of you a 3-month stock, but we give you 3-month stock, but by the time you come, we have nothing. But she's got 3 months. So that is the one reason why we have to actually make sure that we keep this number of stocks available in either 2 or 3 months. The second reason is the issue of having to come and take viral load, which is something very clinical. Because our aim is not just to give you that treatment, but is to know that the treatment is actually working. And I will move quickly to the issue of adherence clubs. Indeed, it is correct that the adherence clubs were actually suspended, especially with the outbreak of COVID. I must safely say, we haven't actually, as a department, taken a decision as to when can we really start reviving the adherence clubs. Of course, we know the value that comes with having the adherence clubs. We have seen it, and we have documented our positive experience that comes with it. So I can safely say that that is something that we'll have to, we will actually consider and look at how best can we actually deal with it in the era of COVID. And I think we will have to have that engagement also with our district partners. I'm not going to say much with the treatment and viral load literacy because I think it's very clear from your report that you were able to see the viral suppression on most of our clients. That indeed we are not where we're supposed to be. We're making actually some progress. But safe to say, colleagues and everybody here, to say, I was listening very carefully to some of the speakers, that there are certain things that you might be experiencing or might be done by the nurses or doctors that might not make sense to you, but they are a requirement in terms of their clinical management of the patient. I will just cite one of those things. One, it is important. One way of monitoring whether a patient is actually taking treatment. It is what we call compliant. Is what the nurses do, what we call pill count. So when that nurse or that doctor asks you that container, how many of the pills or tablets that you still have or that are left, it's not only just to see anything else, but is able to see if, for an example, you have 7 or 8 that are left. She knows what that means. And he or she may be required to do certain things on the basis of the quantities that you are saying you are left with. So, because we do have an experience of clients, a person is saying, I'm taking the treatment as I'm supposed to, but the client is not getting better. So it is upon that nurse to make sure that he has a way of making sure to check if indeed, why are you not actually doing well? So the issue of them asking those things, please let's actually try and make it available. It's not just that they are being impossible, but I think it is part of their clinical management to say, this is what you actually need to do. So that they can better manage or they can better help you. So let us actually take that to say, it's not that they are being sometimes difficult or impossible, but it's just because they are required in terms of how they have to actually provide that particular service. I will go further and then look at talk about the issue of tracing. One sometimes do have an opportunity to be in quite a number of countries. We learn certain things in some of the countries and bring them home in the same way as they learn certain things from us here and they take them to wherever they are. But there is one thing that many people in the world, in other countries, don't understand about us as South Africa and as South Africans. They don't understand why, as government and as a provider of a healthcare service, we should be saying we're having a problem of tracing a client. They ask us quite a lot of questions to say, but how can you trace a client, somebody who needs a service? Because that person does not need to be traced. That person needs to be there for you to get a service because it's for his or her good. They don't understand. Because they believe, they say, in other words, you're dragging somebody to offer a service that he or she does not need. That's how they understand it. And of which part of it is true. I think as South Africans, let us take the issue of healthcare services to ourselves. Let me not entrust my health to somebody else's. And as I say that, I heard some of the speakers to say, some of them stopped treatment because either the nurse was not treating him or her right. Don't do that. This is your health. This is your life. Don't put it in the hands of someone else. Don't. No matter how pushed you are, don't forget that you are the one that needs the service. It's about your life. So let us not make that mistake of really deciding not to continue taking treatment. In other words, you are giving up on your very own life. Let's actually not do that. And thirdly, Let's support each other as families. I'm saying this because I know some of you know what I'm talking about. Where you have, as a person or a member of the family who is sick, but nobody bothers to help him or her to take to the clinic. That person is all by himself or herself. Let us, the support and the care of an individual does not start at a clinic or at a hospital. It starts at home. It's sometimes so disturbing to see or to hear of somebody coming in a facility all by himself or herself, because nobody wants to be there for him or her to support. So let us please support each other as family members, as community members, so that we are there for each for all of us. And I would request that in terms of tracing, let us actually try to keep those appointment dates. For HIV clients, some of the strategies that we put in place to make sure that at least we eliminate these challenges of you guys experiencing in terms of waiting time. When I'm saying you guys now, I'm now speaking myself as a service provider, is that when you are given an appointment, the facility is able to say, tomorrow Tumi is coming, and Tumi is on this treatment. So they should be able to retrieve your file before you come. So they retrieve your file today, because they have an appointment that you are coming tomorrow. They retrieve your file, and where possible, the sister can even look at your file and see if there is anything and put your treatment aside. So that by the time you come the next day, you don't have to wait there. They are able to call your name, you come in, you consult with the sister. If you have no issues, you are okay, you are just here to collect a treatment, the sister issue with your treatment and you go. That is the importance of an appointment system. But if you don't honor that date on which you are supposed to come, obviously, he has to treat you like all those other clients that just came. And has to start with those who are supposed to come today and have honored their appointments. And can we, all of us as organizations, start to actually teach our communities on the importance of some of these interventions as to why are you given an appointment date? Why is it important for you to honor that appointment date? Because it makes it easy not for the facility, but also for yourself as well as you come to collect treatment. Because it's one of the strategies that we are trying to put in place so that we reduce the time that you spend in the facility when you come to collect your treatment. So those are some of the strategies that we are using. Thirdly, we have what we call external pickup points. When you're on treatment and you're doing well on treatment, you are virally suppressed, we are saying the facility should tell you where else can you get treatment, your treatment other than here. Because they do have those external pickup points. Then they can register you there. It can be either a pharmacy or it can be either a certain a GP doctor, but you can get your treatment there. And then you don't have to come and wait in the facility. You can only come to the clinical hospital when you are coming to take blood. So those are the issues that I thought I need to respond to that speaks directly to my program. But the other issues, I think, the HOD will also respond in full in 2 weeks' time. Thank you.
Thank you, Mr. Nkosi. So, yeah, I know we are running out of time because we thought that we will manage to end our meeting earlier. However, we have our last person to respond. Oh, Chico, abanye abantu. So we have Mrs. Maleka who joined us, sorry, Mrs. Leta Sishoka, a programs manager of HIV and AIDS and STI cluster from the National Department of Health. She has joined us virtually and she will just have few words. Unfortunately, Mr. Nkosi took all your time, but we will give you some time to respond on the other things. Yes, we can hear you now.
Okay, I wanted to use the earphone now that putting me at a corner. Okay, but good afternoon, everybody. Protocol observed. Thanks, my counterpart, Mr. Jumi. Just to say, he did touch on most of the things that I wanted to comment on, which is challenges that meet us as a team, starting from national up to work hand in glove in terms of improving the quality of services, especially the HIV services. Just to comment, I've heard they talked about the issue of the missed appointment and also maybe the patients that come back where they were lost or stay for some days or even a month, then they come back to get the treatment. I think that has to be also the strategy within the facility to say, if patients were found to be lost and they are coming back, how do we welcome our patient as a team in the facility? Not really saying that the patient should be overtake the queue that the people are already on. And maybe also to understand the situation within our community, what makes the patient not come back for the treatment and stay away. And remember, community, the ARVs did improve our lives. They have make our days more to live. And if you stay without them, you won't survive. Currently, we're controlling the HIV. We don't have a cure. So for the ARVs, they've done a lot of job. Hence, our economy also has improved. That people were able to go back and work. And it goes to individual responsibility to take care of his or her health. I think Dumi has talked about that let's take that into our shoulders. So let's look into our welcoming our patient. Even if the patient has missed appointment, how do we talk to our patient, the relationship, the attitude? Because there are problems maybe that makes a patient not to come on that day, but to come after a day or two. And how do we solve that with the patient? And that also makes adherence to be strengthened if the communication between the service provider and the patient or the client is well communicated. And just also to add on the, I think it's more of the CCMDD, where it does help our patient to reduce time of going to the facility every month. As soon as you are stable, you are virally suppressed, you qualify that you'll be given a script for 6 months, but you'll just go to where you have chosen to go and collect the treatment monthly. And hence we are trying to also reduce that queue in the facility. that also linked to the waiting time. It will allow you not to wait in the queue for over 2-3 hours. So if you feel also you are healthy and even the doctor, the clinician says you are now ready to go to external pickup point, look at and that's continuity of care. And that will make sure that after 6 months you come and for checkup and rescript or renew the script. And this thing has been all along in our hospitals where our chronic patients, diabetic, hypertension, when they are stable and controlled, they are given those 2-3 months, 6 months, and they just go straight to the pharmacy when they go to the hospital, collect and go back home. So you find that within an hour, the client or the patient has finished the visit to the hospital because they were just going to collect that. So currently it's good that health have partnered with pharmacists, Abotix and Abotix and all others, NGOs that qualifies to can distribute the packed treatment. So let's make use of that, and that will help us to improve the quality of services. And lastly, I think they did mention the issue around adherence club where the numbers have gone down. I think this is a challenge because it's cost implication. Firstly, it needs people, and people, they need some stipends. And what happened currently, most of our patients, our service provider in communities is our CHWs that are being sent to community as an extension to give the health service. But for adherence club, it has been a challenge. Unless there is funding or funding support from our NGO, if they can assist to say those adherence clubs should come back. But again, based on the current pandemic, it was discouraged because remember now we are going to be closer to talk to each other, to be in groups that might spread the infection. So also from national, that was also one of the recommendations that can we cease having a meeting of the adherence club. We just give treatment unless the client needs some attention, and that will still adhere to COVID-19 protocols as we talk, counsel, and support the patient. I think I'll end here. A lot has been taken, has been said. Thank you very much. Over.
Thank you, Meli Shuka, Raleboa Hulume. So we have come to the end of our public meeting. However, I will make some few closing remarks, and at some point I will respond to the issues that were raised by Mr. Nkosi and Meli Shuka. Thank you very much, colleagues, for the response. And I'll just start by saying we need to also remember that we are living in South Africa, and South Africa has many problems. And for me, as a person living with HIV, to wake up and think that I'm not going to the facility, or today I don't feel like going to the clinic, it takes a lot of thinking. And as patients were saying, that the attitude is the one thing that pushes them away or keeping them away from the facility. So one of the things that we recommended is that nurses, as much as Mr. Nkosi, we are talking about how they're supposed to handle themselves. You know, if that was happening, we wouldn't be having so much high defaulter rate in South Africa. So it means there is something that needs to be done. Hence, we are sitting here trying to raise these issues, not because we want to expose the department, but as watchdogs of the department, as community members, we also want you to improve the services and the nurses to improve their services. So that is number one. To share the recommendations, it's not a problem, they will be shared. And yeah, we will be waiting to get those responses. I'm not sure, that is not my decision, but with the stories, we have a fear because we have experienced a violation of people who have spoken out against nurses in facilities. And there is no protection at the end of the day. Hence, you see most of them here, we never showed their faces because we are protecting them. So we are not sure whether when we share these stories with you, how far they will go. So we are fearing for the safety of the patient and making sure that they still have courage to speak out, because it's not easy for one to come and tell these stories. These stories are hateful, are horrible, and they know that they have to go back to the facility where the very same nurse, UNOMSA, will say, yeah, you went back and talk about me and all those things. Those things are happening every day. So we experience them every day. Also, I want to speak about, I think you need to know that on this project, Richitze, we are monitoring PEPFAR-funded facilities, which are only 43 in Mpumalanga out of 200 and something facilities. So yes, the data that we are providing here, it will talk about mostly focuses on those facilities, but doesn't mean that you cannot refer to other facilities. However, in our dashboard, if you can give yourself time to now and again access it and look at it at our website, www.richitze.org.za. In that, you'll get the dashboard, you'll get each and every clinic that we are monitoring, and you will be able to see those who are doing very well and those who are not doing very well. We really recognize those who are doing very well, and we always talk about them to say they need to learn about it. I think in our first slide of the presentations, we spoke about them. Maybe because you arrived a bit later, you didn't get that. Lastly, I think, yes, we agreed that we will talk about how do we support each other in terms of adherence club and how do we work together in that. However, I'm very much concerned about the pill count part. As much as it's one way of monitoring that a patient is taking pills, but the experience taught us differently. We know that there are patients who are not taking medication while they are in hospital, hiding pills under the pillow, under the bed, and all those things. So in this case, what if the patient knows that at the end of the month I'm supposed to have 2 or 3 pills and take off all those pills and live with 2 and go to the fast? That process is manipulating. I don't think it gives us an honest reflection of what the patient is. And lastly, it's very important, you raised very important things to say, when a patient is starting a treatment for the first 6 months, this is what is happening for the next 6 months. If the viral load is not suppressed, this is that information. Unfortunately, some of us sitting here, we know it. But the question is, are people who are receivers or who are receiving the services know that information? And the only person who's supposed to give that information is a lay counselor at the facility, which we learned from this meeting to say there's no counseling that is happening anywhere in facilities. So we can't expect people to understand these things when they are not taught. And the healthcare provider needs to also explain to say, now, Sibongile, because we are giving you this medication, from here and here and here, these are the steps that we will take. So that when we ask these questions, a person will be able to say, no, I'm given 1 month because I just started treatment. Or I'm given 1 month because they said they have fewer stocks, so for us to share. So patients are not given explanation, which it makes it difficult for us and for them. But that it's not the end of the day. I think moving forward, we will work together. And patients, most of them, they said they need our help. We will continue to raise these issues, and we are happy that you continue to listen to us. We haven't reached the target that we want to reach, as you said earlier, but hopefully that one day we will speak one language to say everything is well. Or 90% of our health facilities are giving quality services to our patients. Or 90% of the patients are happy to go to the facilities. But for now, unfortunately, it's still frustrating. As much as the country is doing very well on other things, but the receiving end, at the end of the day, that's what is important and that's where we need to focus on. So in those words, community, thank you very much for coming out and having isibindi sokukhuluma ngezitori zenu and nimzulu babunkosi ushilo and umamsishuka ukuthi they were listening, bazwile, they will try to assist, they will try to engage with our nurses at some point, and nathi, we will continue to follow up, senze sure ukuthi lezi zinto esivumelana ngazo, nezikhulumile nama recommendation ayalandelelwa yini. So in those words, siyabonga kakhulu, thank you very much.